Inaugural session, that is SZIRACON, 9 South Zone Rheumatology Conference and organized by the Association of Rheumatologists of Tamilnadu. So we welcome all the doctors here first of all, and let's start our session today. So first I welcome the in charge here for the session. So I request you to take over the session, first session.
To see.
A warm welcome to everyone. So without further ado, we will start the first session of the day. So the first session will be chaired by Dr. A. Mahesh and Dr. Venugopal, senior rheumatologist from Coimbatore. I request the chairpersons to come to the stage and chair the session.
Good afternoon. I invite Dr. John Matthew, Professor and Head, Department of Clinical Immunology and Rheumatology. He has done his MD General Medicine, DNB, MNA MS, and DM in Clinical Immunology and Rheumatology. He has 60 publications to his credit and 300 presentations. His area of interest are systemic lupus erythematosus, IgG4 related diseases, musculoskeletal ultrasound, and systemic sclerosis. I invite him to the stage to speak on polyrefractory rheumatoid arthritis, how to handle it.
Thank you, Mahesh sir. Good afternoon, dear friends, teachers, seniors. First, let me congratulate Rajeshri Madam, Arul sir, Nagaprabhu, Madesh, and the entire Coimbatore team taking the lead to organize this year's SZIRACON and the art meeting. And Coimbatore is a wonderful place to be. Before I start my session, one thing which all of us know is treatment of rheumatoid arthritis has changed so much in the past 15 years. And the face of this change has been with medications. Therapeutics has been the cornerstone of management of rheumatoid arthritis. This is actually on 2021 to 23. We looked at our patients with active rheumatoid arthritis, about 350 patients. And these patients were followed up for 3 patients not on biologicals. And they were followed up for 12 months, of which 239 had high disease activity and 219 and 31 had moderate disease activity. And of these patients, 216 of them were in remission at 12 months without any biologicals or any other small molecules. And 54 had low disease activity, and 36 and 14 were in high and moderate disease activity. Just saying that how in our setting, the conventional synthetic DMARDs is still the gold standard for treatment of rheumatoid arthritis. Medications being the cornerstone, the quality of medications obviously so matter. So this is one data from WHO which looked at the medication quality in all over the world, and WHO came up with a recommendation saying probably this is a problem with alarming proportions, and to say that as much as 70% of drugs in some parts of Asia could be fake medicines or counterfeit medicines. And on an average, WHO has come up with a statement saying 1 in 10 medical products in developing countries is substandard or falsified. And of which, actually, this is not particular for Asia. Actually, they looked at drugs on, there is an organization, voluntary organization, Pharmaceutical Security Institute. And when they looked at all random collections of medicines, actually the highest proportion of falsified medicines, they got it from North America, followed by Asia. And so this is a big problem. And then coming to what class of drugs are falsified more, medications for musculoskeletal disease forms an important aspect. Actually, it is the third commonest, one of the first top 5 commonest falsified medication. About 11% of the falsified medications were drugs used for musculoskeletal diseases. And this was the data from 2021. And this is when the government of India came up with a task force to counter this problem with regards to medications. And subsequent to the task force, each drug pack has something called a unique identification number and a barcode. And if we send this unique identification number to the Drug Technical Advisory Board of Government of India by an SMS, you can check whether a packet of medicine is actually original or counterfeit. And this is an article in Lancet which came in 2015, which says that there is globalization of counterfeit medicines. And WHO says that approximately 50% of the drugs which are sold on internet are fake. So we have more and more younger generations going medications on the internet, but this is the WHO data which was quoted in Lancet, the Lancet article in 2015. So one problem with the quality of medication. Second is maintaining cold chain. It's easily said than done, and actually maintaining cold chain requires extensive infrastructure, and it's very expensive to maintain. What happens to many of our molecules, our biological monoclonal antibodies, there is a chemical degradation process where there is oxidation and hydrolysis of the molecule which cause disruption of the covalent bonds. And there is a physical degradation as well where the non-covalent bonds are broken, leaving the effectivity of losing the effectivity of the medications. Another issue which we have to be aware of is many a times patients inadvertently might get the medication liquid preparations frozen. And if a liquid preparation is frozen, it loses its property. And it should not be used after thawing. So the third issue, the first issue was the medication. Second issue was the cold chain. And third issue is adherence to disease-modifying drugs. Many of us practicing physician, we feel, that our patients follow stringently what we say, or at least to the majority of the extent. So we at CMC Vellore in 2021-22, we looked at what is the adherence of DMARDs on patients for rheumatoid arthritis. So we recruited 97 patients who fulfilled the using a medication adherence report scale system, which is a standardized medication adherence scale, and used to assess the adherence to medications. And lo and behold, surprisingly, our medication adherence rate was very low. Actually, the blue one, 37.1111, is the medication adherence rate. About 60% of our patients were not adhering to the medications as we wanted them to be, or in the dosage we wanted them to have it. And we looked at what are the causes for this lack of adherence. There were intentional factors and non-intentional factors. The intentional factors include patients feeling that the traditional medicines were better, including other alternative medicines. They felt the care could be achieved by other means. They felt the condition may not be cured by these medicines, financial constraints, and felt that the medicines were harmful to the body. And many thought the medications were not necessary, and some were tired of taking the medicine, and some were afraid of the side effects. And unintentional factors included inability to get appointment for the doctor to fear of infections, unable to come to the doctor's appointment because of some particular family events, lack of memory, medicine getting displaced, lack of attendance to collect medicines from the shops, and as simple as forgetting to take medicines, and multiple doses of medicines are difficult to follow. So this is the level of adherence to our medications. And is this an Indian phenomenon, or is it a problem with us? Not really. This is an article published in 2015, which showed that the adherence to different molecules by in different studies, different molecules vary, and generally the standards have between 40 to 60%, and this has been proven from studies all over the world. And so that's again not different from what we found in our data. Maybe our data had even less actually. So WHO has come up with this adherence to recommendations for adherence to long-term therapies. So identifying the problem could be with the healthcare system, patient-provider relationship, disease characteristics, and in rheumatic diseases, there is a better adherence if the shorter disease duration, better mental health, lower disease activity, and socioeconomic factors. The psychosocial factors included patients' attitudes towards their disease and treatment, self-efficacy to manage their disease, and social support and environment. So having identified that adherence is a problem for therapy, how do we intervene? So we try to look at different studies where, what could we do to improve patient adherence. So these are several studies from 1998 to 2014 where different number of patients, where the trials were methods were tried to improve the adherence, which included methods to give brochure, leaflets, giving telephonic calls to remind them of taking medications, individual counseling, group counseling, multimedia educational programs, and motivational intervening. And all these number of patients range from less than 100 to larger studies including more than 1,000 patients. And actually in this controlled trial settings, none of these interventions were found to improve the adherence to these medications. So one of the things WHO has come up with saying that probably innovative e-technologies may be a way we can improve the patient adherence, which may be a very important part of treatment. Now coming to the fourth important issue, we have to, all of us work in India and we have to consider the reality of India in time. And actually, this is data from 2022. 50% of the population, or our population, earn less than 1,25,000 per year. That is like 10,000 per month. And another 20% earn between 10 to 20,000 per month. Those together make about 70% of our population. Another close to 20% earn between 2.1 to 4.2 lakhs. So altogether, about 88% of our population earn less than 4.2 lakhs per year. Now coming to our medications for rheumatoid arthritis, we are fortunate to have such a varied spectrum of medications available. And I just try to collate the cost of each of these medications per day and per month. And so we have hydroxychloroquine, methotrexate, sulfasalazine, azathioprine, iguratimod, tofacitinib, rituximab, and leflunomide, which could cost less than 1,000 or around 1,000 rupees per month, which each of them. So I would say, like, for the 85% of the population, these drugs are quite good and effective, and we have availability. And then we coming to the biologicals, rituximab, Enbrel, etanercept, adalimumab, golimumab, infliximab, and then the small molecules. All these, probably the cost range coming to about at least more than 1 lakh for every 6 months. Probably the 11 to 12% of our population, this should be okay. And there are drugs which we don't have, which down in the pipeline, which would be available in India: ubadacitinib, filgotinib, or peficitinib, abatacept, or sarilumab, or subcutaneous infliximab. It is in this context, I would like to put this data again, saying that 84% of our patients go into remission or low disease activity in a year's time with conventional synthetic DMARDs. This is an important side why I put this is, of the 320 patients we had, at 3 months, we had only about 60% of the patients going into low disease activity. And by 6 months, we had close to 80% of the population, of the patient population, going into low disease activity or remission, meaning that, we have to give time to medications to act. So one of the things probably we tend to do is, under pressure from patients for activity or need for instead of anti-inflammatory, we may tend to change the disease-modifying drugs. But this data clearly shows that even though 84% achieve remission in 12 months, it's only 60% who achieve low disease activity in 3 months. And so another problem we face is fibromyalgia and rheumatoid arthritis. All of us commonly see that. And this is a paper in Oxford 2018. They looked at, this is a systematic review and meta-analysis, and they looked at about close to 300 patients with rheumatoid arthritis with fibromyalgia and 1,500 patients of rheumatoid arthritis without fibromyalgia. And they looked at the DAS28 scores. And consistently in all these group of patients, the patients with fibromyalgia had a higher DAS28 score than patients without fibromyalgia. Meaning that, fibromyalgia significantly contributed for their symptoms, and it is the fibromyalgia which needs to be addressed, not probably the inflammation. And in a proportionate meta-analysis for all these studies together, the overall prevalence of fibromyalgia was about 21% across all these studies. Another common issue which faces with disease activity, this is a sort of joint we see with a certain duration of time, and at least in some patients, it may be difficult to differentiate, is this pain really mechanical or inflammatory? Particularly in a very busy practice setting, is this actually mechanical pain or is it an inflammatory pain, which could be any of the damaged joints or the damaged limb. This is a study in 2016 where 77 ACPA positive RA patients were enrolled for a longitudinal study. They were followed up for 1.5 years, and they were followed up with high resolution peripheral quantitative CT of the hand. And they found that these group of patients developed osteophytes with time, and the prevalence of osteophytes at the end of the study period correspond to the age of the patient, disease duration, and bone erosions, indicating development of secondary OA in patients with rheumatoid arthritis. So all symptoms of joint pain need not be inflammatory joint pain. Another common problem we could face, this is one of our patients with rheumatoid arthritis, low disease activity, still complaining of pain. This patient particularly had complaints of bilateral shoulder pain and inflammatory markers, low grade, high, but no fever, no other symptom. On further evaluation, she was found to have tuberculosis of the shoulder. So this is a spectrum of problems which comes to us with rheumatoid arthritis patients with inflammatory symptoms or joint pain. Another issue is rheumatoid arthritis one single type? We go by the phenotype, particularly in terms of disease activity, serology, ultrasound, or X-ray. Do we have to go further? Genetically, are they different? Or histopathology of the synovium, are they different? And do we have to modify medications or titrate medications based on that? That's where the precision medicine comes. Maybe the future will tell us whether we have to modify target medications based on synovial histopathology or genetic studies. Now, just a word about resistance to initial DMARDs. Failure to achieve remission or low disease activity, in the standard definition would be 3 to 6 months, or you have a glucocorticoid therapy of more than 5 milligram per day chronically, or you have multiple courses of steroids and which exceeds the dose of the chronic steroid therapy use, or it could be a continued progression of the disease. And this is where the European concept of difficult to treat RA came. All of us are familiar with this now. And one is the failure of the Euler remission criteria, then signs suggestive of progressive disease, which could be either DAS score activity or clinical features of disease activity or steroid use more than 7.5, or rapid radiographic progression documented, or all these 4 are not there, but still the patient is not, the quality of life is not better despite controlling the disease. And the physician as well, physician and or the patient feels uncomfortable with the symptoms of RA. This is a concept of difficult to treat RA, and many of the European cohorts have said that probably 5 to 20% of our RA patients, of their RA patients, could be difficult to treat. And what do? You use a medication with a different mechanism of action, different biological or different targeted synthetic DMARD, and then try to change the course of the disease. So implication of difficult to treat RA is, other than the systemic resistant inflammation, systemic comorbidities of exaggerated inflammation, and long-term consequences, and patient-reported outcomes like depression, pain, and fatigue. And this is a complex interplay of probably the number of DMARDs you use, the sequence of DMARDs you use, the type of DMARDs which has failed, and the duration which we have used it, and the dose of glucocorticoids, and the level of non-responsiveness. At this background that in 2023 EULAR, this poster was presented where they came up with this, they reiterated this concept of polyrefractory rheumatoid arthritis, where this is the Leeds teaching hospital. Remind me, this is a tertiary care teaching hospital where you get only referred patients from other centers with rheumatoid arthritis, and they had 1,600 patients, with 200 patients had difficult to treat RA, of which 40 were polyrefractory RA, meaning they failed all classes of biologicals or targeted synthetic DMARDs. And of these 287 patients, 107 had an ultrasound, of which 46 did not show any ultrasound changes of active inflammation, meaning no Doppler signals or no proliferative synovial inflammation. And 57% patients had some swollen joint count, more than normal CRP levels, and a DAS28 CRP score, which is showing disease activity. And of this 40 patients who had failed 5 biologicals, of which all those 5 biologicals have documented there, there could be 2 subsets. One which showed some ultrasound changes of inflammation, and some which did not show ultrasound signs of inflammation. The one which showed ultrasound signs of inflammation, that active inflammatory resistant rheumatoid arthritis, or PIRRA, and those who did not show ultrasound evidence of this non-inflammatory resistant rheumatoid arthritis. So they grouped into 2, non-inflammatory rheumatoid arthritis and persistent inflammatory refractory rheumatoid arthritis. So is this a reality? I'll skip this slide. And for their group of patients, for this tertiary care hospital, 15% of their patients were difficult to treat, and 2.5% of all the rheumatoid patients, where they put it as persistent resistant rheumatoid arthritis, and of which the 2 groups between the persistent inflammatory rheumatoid and non-inflammatory rheumatoid, the non-inflammatory had higher body mass index, higher rates of fibromyalgia, and inflammatory reactive resistant rheumatoid arthritis have low BMI, higher CRP, higher swollen joint count, and higher DAS28. So how do we manage this group of patients if this patient happens to be in our setting? Add additional DMARDs, or switch patients to a different DMARD or a DMARD combination, and treating the active inflammation with anti-inflammatory therapy, and drug of choice to be tailored to the individual patient. And as I said before, the persistent, before we say it's resistant, we should give a trial of more than 3 months, particularly if there is a partial response to the progressive improvement. And for patients resistant to initial DMARDs, you can switch to biological or targeted synthetic DMARDs, or with a different mechanism of action, or triple therapy with the conventional synthetic DMARDs. Just one statement is, never combine a biological DMARD and a targeted synthetic DMARD. And these are 2 trials which have, I'll just skip that. Now coming to the answer to the question, how to handle it. Counterfeit drugs, ensure quality medications. Drug compliance, probably innovative e-technologies would help. Cost of drugs, shared decision making, government policies, advocacies. Secondary degenerative joint diseases, careful assessment of disease activity, clinical serological imaging. Mechanical pain in deformed joints, treat obesity, physio and occupational therapy. Fibromyalgia needs to be treated. There are still questions, does this entity really exist? this, we have to remember that the concept which they brought forwards is from a tertiary hospital with referred patients, and it's an ultrasound guided definition which may always not be acceptable. So what if it's a persistent inflammatory rheumatoid? Then there may be a point of changing the biological or targeted synthetic DMARDs or the conventional DMARDs. If it's non-inflammatory, then need not add or need not change the immunosuppressive therapy. Probably that's the way you would look at polyrefractory rheumatoid arthritis. Thank you.
Thank you, Professor. I call upon the next speaker. We would have the question sessions after the 3 speeches. Dr. Padmanabha Shenoy, MD Internal Medicine and DM Clinical Immunology. He did his MBBS from the University of Kerala with 10 gold medals, MD from JIPMA with 4 gold medals, DM in HEPGI Lucknow, first Indian in 72 years to present in a plenary session at American College of Rheumatology, recipient of DRA Young Investigator Award, Indo-UK Fellowship JCR Fellow, Clinical Immunological Society, and Fellowship APLAR Young Investigator. Research interests in scleroderma, immunogenicity of COVID vaccines, and palindromic rheumatism. He has more than 50 publications in Lancet Rheumatology, Annals of Rheumatic Disease, New England Journal of Medicine. Your podium, sir.
Good afternoon. Thank you, sir, for the kind words. And at the outset, let me thank Nagaprabhu and the entire Coimbatore team for the kind invitation and excellent hospitality. So, this talk is about B-cell targeting in rheumatoid arthritis. So, topic given to me was what is new. So, then I started hunting what is new in B-cell targeting in rheumatoid arthritis. So, when you look at B-cell, this is a B-cell. B-cell is one of the favorite targets in not only rheumatoid, in lupus, ANCA-associated vasculitis. Wherever you see rheumatologists want to deplete B-cells. How can the B-cells be depleted? What we have been doing currently, the favorite target is rituximab. Over rituximab, because it was a chimeric antibody, reaction was there and B-cell depletion was not that powerful. Then we have orselizumab, ofatumumab, and veltuzumab, and latest, but what we is likely to come to clinic is obinutuzumab because of the novelty trial and the data in lupus. Then we have anti-CD38, which is daratumumab. Anti-CD22 is ipratusumab. And then we have CD19 targeted therapy, which have slightly wider scale of application because of the extensive depletion of the B cells. And CD19 targeted CAR T cell, Dharman sir will be talking about in detail tomorrow. And CAR T cells can not only target CD19, it can also target the BCMA, it can also target the BCR, it can target variety of receptors on the B cells and it can deplete it. And there is anti-BAFF receptor antibody, especially the belimumab is what we know of, but ianalumab is one thing which is coming up, especially in Sjogren's and scleroderma, where ianalumab is an anti-BAFF receptor antibody. So binding on the BAFF receptor, not only it can block BAFF, it can also induce the apoptosis of B cells. So it has dual mechanism of action. That is a newer molecule, very promising drug again. Atacicept and telitacicept has been there in the market for a long time. It has not stood the time of the for some time, and BTK inhibitors are were there, but most of it is not a great story. So one thing we should always remember is that what target we are using, depending on what target we are using, we will get a different kind of depletion, and CD19 is the one which has the maximum from the pro B cell level to almost till the short-lived plasma cells. So that has the maximum amount of depletion. That's why people start using CAR T CD19 therapy, and also CD19 gives a lot of bandwidth for the depletion of the B cells. CD20, in CD20, as all of us know, pro B cells get spared. So when I started looking at this data, there was only phase 1 and phase 2 data of all these molecules tried there, some safety data, not very exciting. Then I received a mail again from Nagaprabhu telling that whatever data we say has to be really to the Indian context. So I thought I will present one paper which is really exciting, which appeared in Nature Medicine this time, and then come to the whatever is applicable to clinics and what we have learned in using rituximab which you can translate to the clinics. What is a BITES? Does anyone know? So this is new. BiTEs is nothing but bispecific T cell engagers. Bispecific T cell engagers, they kill the B cells by engaging the T cell. Can anyone know what is it like? It is like a CAR T cell, but it is an antibody. How does the antibody look like? This antibody is very simple. It's called single chain variable fragments. These are all single chain variable fragments. This will come and bind to the CD3, and the other one will come and bind to the CD19. So on the one cell, on the one side it will come and bind to the B cell, and other side it will come and bind to the T cell. So the T cell will come and, it is a marriage of B cells and T cells, and T cell will come and kill the B cell. That's how, it's a very novel concept. It's called, this is a novel concept, and the molecule is called blinatumomab. Blinatumomab and ALL, they have used it very successfully. And so B cell is there. You can see CD19 comes and binds, and the short chain, single chain variable fragment of CD3 will come and bind to the T cell. CD3, we know, is a pan T cell marker. So CD4 and CD8 T cells will sense that this B cell has to be eliminated, and B cell will get killed. So in this paper, which appeared in Nature Medicine, very exciting data. So they took 6 patients, very initial data, 6 patients. Most of them have failed on multiple DMRs. You can see, what sir told, polyrefractory disease, and half of them had failed on rituximab also. And most of them were seropositive except one patient. So what do we really do with this patient? So this molecule was available. So they gave it a very, very low dose. You can see the dose. They gave 9 microgram per day, 9 microgram per day, very minute dose, and 2 doses. On the week 1 and week 3, they gave this dose, and they were admitted, they were monitored. What they could see was that, and they were maintained with abatacept. After 12 weeks, they were given abatacept, co-stimulation blockade. So what did they see? Fantastic. Look at the tender joint count, look at the swollen joint count, look at the patient global assessment and CRP. All of them, and most of the patients attained remission. All the 6 patients who were polyrefractory attained remission, so very good data. They did this fantastic, some interesting images. FAPI-PET. FAPI-PET is nothing but a fibroblast activation protein inhibitor. So based on this protein, they can map the joints. Look at the joint inflammation here, vis-a-vis here. It's almost nil. They have done biopsies also in 3 patients. You can see what happens to the joint which was inflamed, lot of paresis there, inflammatory cells have decreased, CD20 and CD19 almost is non-detectable. So what they could show was that, from this data it's very clear that these BiTEs can be a useful thing for rheumatoid arthritis, and it's a novel mechanism, and it is maybe much safer than CAR T. We don't know yet because there is no long-term data, but at and the dose they have given is, as you see, 10 micrograms per day. It's a very, very low dose. So food for thought. It's a T cell dependent B cell depletion like CAR T cell, but without long-term risk, because drug is not going to last there for long term. And more importantly, what I think is it can target different antigens. It's not only CD20 or CD19 or BCMA. You tell another antigen tomorrow in AS we have another antigen, it can target that. So this therapy, this antibody design, I found it very interesting. And I think it is worth exploring in coming years. Then there are phase 1 and phase 2 study. I didn't want to bore you with all the phase 1 and phase 2 study of these molecules, and most of them, as you know, the data is similar to rituximab, and I am sure the value add which they are going to do our practice is going to be minimal. So then I thought I will talk to you about one of my favorite topics, what dose of rituximab is effective. This thought has been, last week also when I was there, then Mr. Sir was telling this low dose rituximab doesn't work. So I have not spoken about this to most of you, so I thought I will just present this data. So this is I have been always a fan of low-dose rituximab at our center for last 10-12 years, and a lot of people have taken it up also across country now. So this is one study, two studies which have landmark studies of rituximab. One is Edwards paper and then Dancer study group. Edwards paper was the landmark New England Journal paper which gave 2 grams of rituximab along with cyclophosphamide. Very effective. It showed the efficacy of rituximab. The Dancer study group showed that 500 milligram rituximab is equal to 1 gram rituximab is equal to 2 grams. This is the mirror study, again shown that the clinical data as well as radiological data is almost similar. So do we really have an indication to give a 2 gram of rituximab to our patients? The answer is no. And this has been proven by meta-analysis also. In most patients, 1 gram of rituximab is equal to 2 grams. So my question always has been how low we can go. Then if we go to the original paper, so I started hunting. This is a work which I have done 3-4 years back. So I started hunting the original paper of rituximab, because I always think that pharma companies promote higher doses for higher sales. Obviously, they are looking at profits for their own benefits. Look at this 1994 paper of IDEC CD28 antibody. What can you see here? This is the name of rituximab at that time. They gave it to 15 patients, and what they could see that they gave single dose of 10 milligram, 50 milligram, 250 and 500. What could they see? Most patients, whatever their dose gave, their B cells got depleted. And what happened? B cells got rapidly and specifically depleted in peripheral blood 24 to 72 hours and remained depleted for 2 to 3 months, even in very, very low dose. 50 milligram it was depleted. And then what happened? This is the phase 1 trial of NHL. Look at the doses they were given, 125, 250 and 375. Look at the remission rates, almost similar. So, but what happened? They chose the higher dose, obviously, because we are treating lymphoma, which is a life-threatening disease. They will chase least toxic dose, which is more effective, and they want to have a profound B cell depletion. And that is the reason in autoimmune diseases also, this is the first paper in ARD 2002, that rituximab 600 milligram per meter square dose was taken without much real rationale behind it. We cannot equate malignancy to rheumatoid arthritis, where we don't want that depletion. So let us look at some pharmacokinetics of this molecule. This is rituximab. What they have done is, they looked at the EC50. EC50 is effective concentration 50. So that is EC50 of rituximab is only 1 microgram per ml, and 10 times of that is 10 microgram per ml is enough for depleting the B cell in the body, in all human samples tested. So 10 microgram per ml is enough. So what dose of rituximab is required to reach this 10 microgram per ml? So this is slightly complicated because we don't deal with it this commonly. Look at this. This is one study where they gave 100 milligram, 250 milligram and 500 milligram. In each of these, even if you give 100 milligram, the concentration achieved is 100. What is the concentration required to deplete B cells? 10. So by giving 100 also, we are achieving it much higher. By giving 250, it is almost 500. So indicating that by giving the dose what we give is much higher than what is required. So this is again the data from a biosimilar study. What they could show was that this is 500 and 500 and 375 milligram meter square, and the last one is 100 milligram per meter square. Even with 100 milligram, you can see here almost for 6 to 8 weeks, the rituximab level is about 10. So this is enough. That is very clear. So we studied. So this is very clear that even if you give 100 milligram rituximab, we achieve enough drug levels to deplete B cells. So this is a study we did long back. We took 12 patients. I don't want to go into it, but and give 100 milligram of rituximab, and you can see here around 80% of our patients responded. So we got fascinated with this our study, which was done I think 2014 or 15. But what happened was that long-term follow-up of these patients, all patients lapsed in 5-6 months, and 30%, one-third of them did not respond even to 500 milligram. So I was a bit scared. I was not sure, maybe it is HACA. I didn't have the facility to check at that time. And needs an RCT, we had applied for DST last 2 years back with a multi-center study with Amida ma'am and all, but it never got funded. So 500 milligram, it was very clear. I was very convinced because we have been using rituximab for a long time. If someone does not respond to 1 gram of rituximab, they don't respond to rituximab. Odds of achieving remission by giving another 1 gram is less than 10%. So my conviction was, if somebody does not respond to 1 gram, there is no point in giving next dose. In most of the patients don't respond, and better to change to another mode of therapy because most of the time patient pays from their pocket. So we designed this protocol some time back. We give rituximab 500 milligram from 2014. I am following this. So after 6 weeks, we will assess response, clinical response, and what is response? Decrease in DAS28 more than 1.2 or any EULAR response, delta DAS of 1.2 or any EULAR response. So if the patient responds, they go into follow-up phase. If the patient do not respond at 6 weeks, the patient is labeled as given another shot of rituximab, and if the patient responds, yes, fine, goes into maintenance phase. Otherwise, no response, patient is labeled as rituximab failure. This we have been following for a long time religiously, and this is a paper which was published in 2021 with 137 patients. Now I think we will have 500-600 patients. That time 3-year data was published, and most of the patients were bio-naive, and we only rituximab to seropositive patients, and DAS28 you can see very high DAS28 6. And most of the patients were on conventional synthetic DMR, combo DMRs, and quite stiff dose, methotrexate of 16, mean dose. This is sulfasalazine, and most of them were on combo DMRs. And response, if you see the so in 137 patients, 108 of them responded to rituximab. 108. And they went to follow-up phase. Of those patients who did not respond to first 500 dose, of 29 patients, we gave second dose of rituximab, 19 responded, and others were labeled as non-response. So out of 137, only 10 were rituximab failures after giving less than 7 to 8%, which is what most of the studies show. So if you look at the ULR response, what we can show is that non-response, 7% were non-responders, 48% were moderate response, and 45% were ULR moderate responders. So if you look at the moderate and good response, which is a reasonable target what we can achieve, 92% achieved moderate to good response, and around 26% were in remission, and another 19% were low disease activity. So 45% were low disease activity plus remission. So I think this low dose rituximab protocol works, and this is our protocol with the 2-gram dose protocol, which is almost similar. So we do flow cytometry also. So question is, does the peripheral B cell depletion really affect the outcome? The answer is, we do at 0 weeks, 2 weeks, and 24 to 26 weeks, whenever the patient, we expect the B cells to repopulate. B cell depletion following the first infusion happened in 112 patients. Out of 136, 112 achieved it. But 25 had incomplete depletion and did not predict the response. So really speaking, whether we need to do B cell numbers, that is not must, but because we are giving a lower dose, we have been doing it regularly, but if now we have reduced the threshold of that, it is not a must to do that. But B cell depletion at 2 weeks, very, very importantly, because somebody will say full dose, they will come back, read up and somewhere, why I am not giving 2 grams, we can always say that your B cells are depleted. So it's reassuring to patient, and I am sure it will increase the clinician confidence to great level. So when do we retreat? When the patient relapses. This is again the same data. Some patients of us receive 8 months, 10 months. We need to write a paper on this. Fixed dose regimen, how long, what is the average dose required, but of thumb rule is 8 months to 12 months is most of our patients require. So the cost of therapy is really, really low to these patients. So what can be done from this talk? What can we do now? Now is lower dose can make a difference to lots of our patients because lower cost, lower side effects. In the era of JAK inhibitors, rituximab versus tofa, because tofa is on the very easy to be written. So should we prefer in conventional synthetic DMR failures tofacitinib as the first agent? To me, no. In rituximab, I always prefer in seropositive patients because cost is almost similar, 1,000 rupees, because your rituximab per month will cost 1,000 or 200, 1,500 if you divide with current cost. So cost is almost similar, and definitely side effect profile is much better. And future, definitely there are newer agents coming up with novel actions. They are all in pipeline, and in resistant cases, I am sure these kind of newer drugs in B cell depletion here is to stay despite tofacitinib or newer agents. And they will come to market, and other drugs, but whether they will add on to rituximab, how much they will add to rituximab, above rituximab, I am not really sure, but data will come in coming years. Thank you for patient listening.
Thank you, Dr. Shenoy, for your wonderful talk. The next speaker is Dr. Raj Kiran from Hyderabad. He is going to talk to us about RA-ILD, to treat or not to treat. Raj Kiran, I think, is quite well known. I don't think he needs a very formal introduction. Over to you, Raj.
Thank you, sir. Thank you very much, Nagaprabhu sir and Arulaj Murugan sir, for asking me to talk on this topic, RA-associated ILD, to treat or not to treat. I am a purely practicing rheumatologist, so I always feel like treating these patients. And in the next 15 minutes, I'll try to convince you why we need to treat these patients. So prevalence and incidence varies, RA-ILD. It depends upon the case finding methods and the denominations, what they do in their studies. So subclinical findings, if you take chest imaging, you might find 40% of patients of RA have ILD, and autopsy studies have shown around 35 to 40%. But clinically significant ILD is seen in almost 2 to 8% of the patients. So in clinical practice, if we are proactive in looking at ILD, we may find more cases. But if you evaluate only when patient has symptoms, we may find it less. So this paper looks into RA patients with and without ILD, published last year. and it had shown a prevalence of 4.1%, which is clinically significant, and 90% of the patients had rheumatoid ILD after diagnosis of RA, and 10% of the cases had ILD prior to the diagnosis of articular RA. And time of onset of ILD in these patients is 3.3 years. And it has been observed the clinical characteristics of the patients who develop RA-ILD are elderly male, those with severe RA and with high inflammatory markers, CDI, and with high anti-CCP and rheumatoid factor positivity. Though RA is common in female, but RA-ILD is more common in males. If we look at ILD subtypes, UIP is the most common one. So 50 to 60% cases of RA-ILD are UIP, and 30 to 40% are NSIP, and desquamative IP, organizing pneumonia, and lymphoid IP shares the other group. So when we make a diagnosis of RA-ILD, we also need to look at overlap syndromes, whether the patient is having an overlap of scleroderma or MCTD or any other CTD. And if there are certain ambiguous findings on CT, we can always ask for a biopsy. And one syndrome, just to mention, COPA syndrome, where the patients have COPA gene, and it's more common in young children and adolescents with fever, arthritis, and ILD. These patients can have high titer rheumatoid factor and anti-CCP positive. The case reports are also been presented in the last 1 year, which is seen in adults also. So this is very, very interesting paper published last year. It has looked into the incidence of ILD in patients who are on biologic DMRs and targeted DMRs. And this is very, very refreshing and encouraging news for us Indians. Like in this retrospective cohort study in patients with RA, it has been observed there is significant reduction in the risk of developing ILD in patients on tofacitinib. So tofacitinib scores over remaining all biologics, including rituximab and tocilizumab. So what about the survival of RA-ILD patients? In this summary results, if you see, those patients with RA-ILD with UIP has a significant mortality at the end of 1 year, 9.1%. And patients with NSIP, especially cellular NSIP patients, did fairly better with 5.6%. And if you look at the bottom, the interesting thing is this is a meta-analysis of last 20 years. And the data which is prior to 2010, we can see the patients had 19% mortality in the cases of RA-ILD within 1 year. But the mortality has significant decline in the data which has been collected post 2010. Could be related to the JAK inhibitors and other biologic drugs and more aggressive treatment of RA. So RA-ILD patients do die. They die much earlier than RA patients without ILD. The risk of death is 3 times more in RA-ILD patients. The 10-year mortality is 60% in RA-ILD compared to patients with RA who do not have ILD. So natural history, it varies, depends upon subtype. Patients with UIP do not do better, whether cellular NSIP do fairly better. And disease activity, if rheumatoid arthritis is controlled well, so the natural history might vary. The patients might not progress. It also depends upon the choice of DMRs what we use and medication, and especially in countries like India, compliance. So more often when the patient develops an ILD on treatment, it's he has been he will be told by nearby doctors or someone the cause of ILD is the medication what he is taking. So this adds more problems to the patient. So there are chances that they might stop the medication further, and it might still further sink the clinical condition. This is quite common in our Indian scenario. And access to treatment facilities. This has to be treated multidisciplinarily with radiologist and pulmonologist together. Sometimes access to all specialists might not be there. And frequent infective exacerbations, poor socioeconomic conditions might create problem. And associated comorbidities, diabetes, obesity, these may alter the natural course of ILD. So the natural course is heterogeneous and variable and might vary from patient to patient. So if you look at this paper where it has looked into clinical course of RA-ILD patients in first 2 years after the diagnosis of RA-ILD. So patients with fibrosing ILD had did much worse. So the death, almost 15% have died, and nearly 5 to 9% patients had significant decline in FVC, And there is a relative decline in nearly 28%, up to less than 20% of FVC decline has been observed. So coming to clinical case scenarios, this is a 68-year-old male who had high titers rheumatoid factor, anti-CCP factor positive, and he is having RA since 10 years, and currently he is in remission. He has a stable doses of MTX and is smoker, and there is a history of COPD. What is the risk of ILD in these patients? Do we need to evaluate further? What shall we do? So now if we look carefully, if we dissect him and see, so he is an elderly male with high titer CCP positive, more than 10 years of disease, smoker and COPD. All these things will put him at a risk of developing ILD. And certain good things, the disease is in remission, so it protects him from ILD, and he is on MTX. It has been, we have got enough data in last decade that MTX protects patients from ILD. And recent ACR EULAR guidelines also tell if you diagnose patient ILD on MTX, you can still continue MTX. So when to screen for CT chest, we need to use our clinical knowledge. Just check clinically whether the patient is having Velcro crepes, is there any history of shortness of breath, cough. Then you can get a screening CT chest, or we need to carefully watch these patients. So RILD risk factors, male patient with MUC5B promoter variant, those patients who are having this promoter variant gene have a higher risk of developing RILD, and smoking and obesity put them at more risk. And RS specific risk factors like older age of RI diagnosis, male sex, longer disease duration, high disease activity, and high antibody titers. A point about MUC5B promoter variant. This is also a common variant gene abnormality noticed in patients with IPF. They have a bad prognosis, and those patients who have this variant in RA, they have a higher tendency to develop ILD, and this correlates well with development of UIP subtype. So we need to investigate when RA-ILD is suspected. Why? Because these patients can have a significant loss of FVC, and there is a significant diagnostic delay in RA-ILD, and this itself can be an independent risk factor for mortality. And case 2, here we have a 50-year-old female who has rheumatoid factor positive RA, and she is a 2 years duration with MTX. She is on MTX and Lefno. Still her disease is active. She comes with dry cough, shortness of breath, and CT shows UIP pattern. How to approach and what to do to this patient? So clinical examination thorough. After that, chest X-ray, PFT, DLCO, 6-minute walk if the patient can do. Then HRCT, cardiovascular GI workup to look for other causes of shortness of breath and cough. Bowel and lung biopsy when there is an atypical setting. And we need to involve our pulmonology and radiology colleagues. And nowadays, there are some papers and some people are doing lung ultrasound to look at B lines to identify early ILD. And certain things which are very important when we ask for imaging. So supine imaging might show some haziness, which might give us a feel of ILD. So when there is a suspicion in early stages, it is always better to take a prone image, which gives a better quality films and which excludes these artifacts. And it's always better to take a good expiratory film compared to inspiratory film, because of inspiratory film, again, there might be air trapping, which might give us a feel of ground loss. There are small basic things which might again prevent us from over-diagnosing RILD. So management, fibrotic disease, antifibrotics, inflammatory disease, these are the drugs. And acute exacerbations, we use intermittently steroids, and very severe disease, we try our luck with cyclophosphamide, lung transplant, and as tacrolimus as add-on therapy. So this is the proposed management of RA-ILD, so published last year. So if the patient is asymptomatic, ask him to stop smoking and control RA well, and we need to vaccinate these patients to prevent frequent infections with flu and pneumococcal vaccine. So if the patient is asymptomatic, wait and watch, do frequent follow-ups, maybe PFT once in 6 months should be good enough. If the patient is having mild disease with less than 10% fibrosis on CT, same principles. And if the patient is progressing, if he or she is developing symptoms, if the pattern is NSIP, start steroids and DMARDs, adjust DMARDs. If the pattern is UIP, immediately start antifibrotics and adjust RA medications. And all this, in all these cases, we need to control RA very well. And we need to know that it's not always that articular symptoms correlate well with lung symptoms. Sometimes there might not be articular symptoms at all, but lung symptoms might progress. So assessment of lung symptoms is also very, very vital. If there is a moderate disease, if the patient is already on methotrexate or any other drug, we need to change the DMR. So if articular symptoms are quite high, we can think of adding rituximab or abatacept. And if articular symptoms are not there very significant, MMF also can help. And in UIP, antifibrotics and adjust RA medications. In severe diseases, we need to start discussing about lung transplant process. So antifibrotics, nintedanib, last year paper, it has shown a very good significant prevention of FEC decline in patients who are on antifibrotics, nintedanib, compared to the patients who are not on antifibrotics in RA. So MMF is a good drug for lung, but it has a poor efficacy to control articular manifestations. Whenever we are using MMF in treating lung predominant ILD, if the patient has articular symptoms, MMF alone may not be helpful. We should add another medication to control articular symptoms. So rituximab had shown benefit in RA-ILD progression compared to other biologics. Cyclo we use in severe diseases. Tocilizumab, it's interesting, it's approved in systemic sclerosis ILD, but again RA-ILD, it has not shown that promise. But however, in patients with RA, with significant arthritis with ILD, this can be a good choice. Methotrexate-induced pneumonitis is not very common. MTX in incident RA-ILD, if you look at the data, there is no risk of increased ILD in patients who are on methotrexate. It's always better to obtain a chest X-ray before initiating methotrexate. TNF inhibitors have absolutely no efficacy on ILD. This is what the data tell. And it's always better to avoid initiating in patients who have a clinically significant ILD. And if all patient is already on anti-TNF, and if incidentally like ILD is detected, we can still continue. So coming to case 1, so what shall we do in this patient? So because the patient did not have any symptoms, it's better to carefully watch, do serial PFTs and CTs. And if you, in the follow-up, if the patients develop any symptoms, you can do imaging and we can decide upon the medication. In case 2, because the patients have a significant articular disease, patient is also having a lung problem, the disease is progressing. So to control the articular problems, we can still continue on methotrexate. And rituximab, a drug which we can choose, which will act for both, and tocilizumab is another option. And on follow-up, we can add MMF, because since it is a UIP, antifibrotics are essential. So finally, there are certain new ways to look and predict the mortality in these patients. This paper looks very promising and interesting. Radiomics to predict the mortality in patients with RA-ILD. So in oncology, they use this radiomics to quantification of tumor phenotype and predict the mortality. Similar things have been studied in patients with RA-ILD, and they have observed good correlation. Those patients who have a very high radiomics score had poor prognosis and they have died early. To conclude, there is a high prevalence of subclinical ILD in rheumatoid arthritis. Clinically significant disease is around 3 to 7%. But whatever the significant disease is there, when it is identified, the mortality is quite high, especially if it is UIP pattern. So early identification, aggressive treatment is a better way to protect and prevent mortality in these patients. And mortality in RA-ILD is significantly higher than RA without ILD. So there is insufficient data for evidence-based recommendations on screening and monitoring these patients. So we require an interdisciplinary approach with our pulmonology colleagues and radiology colleagues while treating these patients. Thank you very much, sir.
Thank you, Dr. Raj. Now the topics are open for discussion. I have one question, Raj. When do you want to combine MMF with antifibrotics?
I think sometimes in NSIP we have both fibrotic and cellular type of disease, sir, where we find inflammation in lung as well as we have an fibrosis also there.
You mean established fibrosis?
Yeah, established fibrosis with active inflammation, both of them together. It's not like completely a honeycombed lung, like typical UIP, but NSIP we have a fibrotic and cellular variant. Sometimes both of them can be together in that cases.
And which do you prefer? Which antifibrotic is preferred by you?
Nintedanib is we commonly use, sir. If they don't tolerate, I think pirfenidone, the dose is quite high, people may not tolerate. Nintedanib is what we are using.
Okay, thank you. Any questions? You can address the questions to the respective speakers.
I think, sir, I think before PFT, I think clinical examination, once we do, if we find there is significant symptoms, I think once the patient is symptomatic, I think it's worth doing PFT if rather than. Yes, sir. If we are, I think there is no harm in doing it. It's quite safe test without any radiation.
Yeah, Raj, I just want to share couple of things. Couple of RA patients, RA ILD patients, especially seronegative RA, those who develop ILD. We have 2-3 patients who we just picked up in last 6 months, anti-MPO and or myocytes antibody positive. It's always better to look for additional causes if RA ILD is progressing quite fast.
Yeah, I have mentioned in one of my slides to look for the overlap.
Very important because
yes.
we seronegative, one seropositive patient was Jovan this thing positive, despite not having any other symptoms. So it's always better to, because that changes the entire paradigm how we manage them.
MMF is really not going to work now. But in
For
that
arthritis.
case, can we add methotrexate also?
Yeah.
That combination.
Yes.
What about sulfasalazine? Also.
We can add, madam, but I think we need to move more aggressively. I think methotrexate, MMF, rituximab, I think we need to look at that direction rather than adding sulfasalazine, I think, to the drug which will work for both ILD as well as articular symptoms.
In my practices, when I use igrutimod, especially when we have this kind of situation. Am I audible?
Yes, I agree, sir. I have when I'm reviewing the data.
When you add igrutimod along with mycophenolate maftil, the articular symptoms significantly come down. And to bring to the attention that there is a paper which has been published from Japanese group, where they have worked with igrutimod and mycophenolate maftil combination in ILD of other causes also. They have found a significant increased benefit or advantage with the addition of igrutimod. Yes, Sjogren's paper.
Yeah. Yes, sir, that paper is there. Igrutimod with MMF in
MMF
RA.
is supposed to increase the efficacy of
yes.
To John, sir. Sir, you showed that data of CS DMR, with alone CS conventional DMRs, 90% of patients could achieve remission, 86%. How many percent of those were on steroids, sir? Because 86% remission only with DMRs, maybe a lot of steroids, no?
They were on 5 milligram or less, actually. So if they were more than 5 milligram, they were not included in the remission.
Our CARAC data, which we had published 4 or 5 years back. 4 or 5 years back, I think almost 6 years back, it was almost agreeing with his things. The majority of the patients who are just on conventional DMRs, especially when we go for triple DMR and few with 4 DMRs, they could achieve a good remission. So only, without steroids. Most of them are without steroids. It's almost close to 60 to 70%. Only thing we need to is to wait for the response. The response usually occurs sometime after 6 months to 1 year. I think most of the time I try to counsel my patient that you wait for 6 months, at least a year. And not to go by the definition of 3 months, then we land up in trouble.
And one question for Shenoy, like when you're looking at the lowest possible doses of rituximab usage in patients with RA, like how frequent are relapses in your patient? Because I have observed when I have given a full dose of rituximab, like 1 gram, 2 pulses. So they have a very long phase of remission compared to patients who have this dancer trial model where 500 milligrams. They had more frequent relapses, maybe after 8 months, 9 months, they had a relapse. How is your experience?
Yeah, very true. So the problem is we give only 500 milligram. Most of our patients, as you see, 90% of our patients who receive remission, they get only one dose of 500 milligram. And after that, most of them require another dose in 9 months to 1 year. See, even if you take a 5-year data, these people have got 4 or 5 doses. While in 2 gram data, the initial dose itself is 4 doses. And then after 100, so if you look at the cost of therapy, it is much cheaper, and hypogammaglobulinemia is non-existent. That is a very good advantage, because rituximab, what we are fearing is if you give rituximab for a very long time, higher dose, hypogammaglobulinemias will be higher. I agree that if you give 2 grams, you are likely to get a prolonged B cell depletion, which is going to last for a longer time.
Sir, just 1 minute, sir. And Shanai, like these patients, like whom, like I have used 500 milligrams 2 doses, even they had a significant depletion of CD19 and 20. But still they continue to have articular symptoms. Like, do you check these and give again or redose, or like what is it? Because 1 gram is okay, but 500 milligrams twice I have given, and just when they had a relapse. So when our nephrologist had checked for it, okay, so the both 19 and 20 were almost zero.
You should, when you are giving rituximab, you should never check for anti-CD20. You should always check for CD19.
Yeah.
First thing. And second thing is, you are talking about lupus or rheumatoid.
No, this is RA. Because RA, this patient had a proteinuria, went to nephrologist, and they have checked this. So when the patient came back to me, because we were in a plan of giving another dose of rituximab, they came with a report of CD19, which is 0. Patient has still
See,
symptoms.
if the patient still has symptoms, despite this 500 milligram, you can give another 500 milligram.
So despite CD19?
Yeah. Because CD19 depletion, that's what I told, CD19 depletion actually does not correlate directly with the response.
Because I think in our practice, we look immunoglobulins, we check frequently. I think nephrology society, I don't know, it is your experience.
I have stopped checking.
They keep checking CD19.
Best option is CD19 can just give you a gross. CD19 count can only give you a gross indication of the B cell status, because the trouble is that what you are checking is a peripheral circulating B cells. The troublemakers are not the peripheral circulating B cells. They are all these B cells which are sitting in the tissue or in the whatever the focus. If it's in lupus, it's in the glomerular, or it is in the rheumatoid, in the pannus and those areas. So that's why they don't really truly reflect your thing. So best is to take both. You take B cell, take the immunoglobulin level profiles. If immunoglobulin level profiles are good or fair enough, you can still go ahead with the rituximab. You can titrate the dose to the lower side rather than going to the higher side. Instead of going 1 gram, you can go with 500 milligram, depending on the indications what you are working with. In my experience, what I have seen is with reference to rheumatoid, we can have 500 milligram, it really does well. But when it comes to the ANCA-associated vasculitis or myositis, small doses don't really work. It usually, invariably, you best go for 1 gram or 2 grams of those dosages is something what you have to see. So the basic mechanism, what we always forget is that B cells, what we are measuring, is it what is circulating? And that's not truly reflect the total B cell mass. The B cell mass, what we are to be target, are the mass which is there in the tissue. They are the main culprits, which usually, that's one of the reasons why we sometimes fail with the B cell therapies, because therapies don't eliminate those cells in the follicles. So
but that leads us to another question, whether this rituximab is
I think we have run out of time.
Plasma cells.
Okay, so we'll close the session. Thank you all speakers.
I request the chairpersons to present the memento to the speakers. I request Dr. John Matthew sir to present the memento to Dr. Mahesh sir. Request Dr. Raj Kiran sir to present the memento to Dr. Venugopal sir. Moving on to the second session. Second session is regarding spondyloarthritis. So this session will be chaired by Dr. Rajeshwari ma'am and Dr. U.R.K. Rao sir. So Dr. Rajeshwari ma'am, she is currently the president of ART and she is the professor and HOD of rheumatology in SRMC hospital. Dr. U.R.K. Rao sir, he is currently the consultant rheumatologist in Sri Deepthi Rheumatology Center in Hyderabad. Now on to you sir to stage the second session.
Good evening. May I request Professor Dr. A. Murthy? He's MRCP UK, MRCP Rheumatology UK, FRCP London. And Professor Murthy is a senior consultant rheumatologist at one of the busy teaching hospitals, University Hospitals of Leicester and NHS Trust, Honorary Associate Professor of University. He is actively involved in the teaching, training, and treatment. He is a visiting international professor of rheumatology at Dr. MGR University, Guindy, Chennai. He is a regional specialist advisor for rheumatology at Royal College of Physicians, India. He is the first Asian president of the 50-year-old Midland Rheumatology Society in UK. He also held various positions at BSR, including Regional Advisor Education Training Committee and BSR's Council. He had several awards. In fact, it may get into his time if I continue to read the several awards he is getting for his excellent work on spondyloarthritis in particular and rheumatology in general. He is involved in the clinical and research and was invited speaker for National International Rheumatology meeting as speaker, chairing sessions, and undergraduates, postgraduates, medical education. Dr. Murthy is also an MRCP examiner, and he has guided and mentor of international medical graduates aspiring to work and train in England. So if anybody wants to be in the UK, please catch him hold. The first talk by Professor Murthy is exercise as an anti-inflammatory therapy in spondyloarthritis. Most of our rheumatologists think it's a pharmacotherapy, but exercise, the physiotherapy and exercise are very important, and probably we may a bit ignore that. So Professor Murthy would highlight on that topic. Thank you, Dr. Murthy.
Good afternoon. Thank you very much for the kind introduction, and thank you very much for the organizing committee to invite me to give this talk in this prestigious South Zone Rheumatology Conference. So I'm going to go upon to talk about just a simple overview of spondyloarthropathy, and then going to touch upon the contribution of inflammation in the spondyloarthropathy, and going to introduce the research work which we undertook in our department, and also give some patient feedback, which will be slightly at the later part. So I don't need to give this talk on the idea of concept of spondyloarthropathy. However, we all know there is up to 8 years of delay in diagnosing this condition. However, I can proudly say in Leicester, we have reduced the delay up to 4.4 years and been awarded as a change maker in service for spondyloarthropathy in House of Commons last December. So that leads on to various sort of work which is being accredited. One of them is non-pharmacological intervention of managing the patient with spondyloarthropathy, which is a physical activity and axial spondyloarthritis. So when you do about the literature, there are high levels of physical activities associated with reduced blood markers of chronic inflammation, which is published in 2017 by Dougley et al. And then the regular structured exercises can reduce the pro-inflammatory monocytes, phenotypes, which is also published in 2019. And last 2 years, there is sessions from our group in Loughborough University, which is one of the topmost university in the world for exercise medicine, which has produced single session of structural exercise. Regular physical activity can reduce migration of immune cells to tissue, which enhance the anti-inflammatory effect of our patients. As you can see on the right side of the diagram, where the CRP is also reduced, and people with arthritis, particularly in axial spondyloarthropathy, CRP can be fluctuant, so we cannot be able to identify as a marker on that one. So it's the largest benefit seen with a small amount of exercise, which you do, has an impact on the management of these conditions. However, as a treating physicians, we always talk about non-steroidal anti-inflammatory drugs, and then we get straight move on to biologic drugs. But we don't normally educate our patients, particularly about exercise. If you can see the EULAR guidelines in 2023, we see on the column 4 and 5, there is some education exercise has been mentioned, as well as stop smoking, but it's not been practically implemented in clinical practice. So the management pathway is physiotherapy, and education is a phase 1, and then phase 2 where our drugs, and phase 3 is the new drugs which we can use. These have all been in the highlighted, but in the clinical practice we are not using it. So what we thought was, how about the combination of using physical exercises and using standard non-steroidal anti-inflammatory drugs as well as the biologic therapy. So we start from our musculoskeletal care journal, which we published as a focus review a couple of years ago about lifestyle modification and inflammation in people with axial spondyloarthropathy. What we found is 45 patients of exercise interventional studies, only 82% reported improvements in disease activity. Around 80% improved physical function, and 75% improved the mobility of our patients, particularly about the axial spondyloarthropathy. What about CRP? Only 9 studies has investigated inflammation, only analyzed CRP, no other markers. CRP only improved in 1 study. As we all know, the CRP is a fluctuant marker in axial spondyloarthropathy. So we asked our patient, what do you do as patient perspective? And we presented this in the BSR this year. And moving with axial spondyloarthropathy, a short survey asking our patients, around 266 participants in my clinic asked about the questions about what you do regarding exercise. And you can see surprisingly in this, the female population is more and the male population is less in that group which participated in the study. And then we asked about the preferred activities you do to improve your spinal pain. Is walking was the main one they were mentioning, and yoga, weight training, swimming, and cycling. These are the things which came as a heterogeneous pattern. Particularly about walking and yoga is the main thing which has been highlighted for that. Obviously, there is a barriers. In England particularly, there is not much facilities available for hydrotherapy and the cold climate, etc. Not only that, our patients worried about the flare-up of their condition because they do exercise, and they worried about fatigue and not having enough time, not knowing enough about the exercise, lack of available facilities, etc. And if you're given a preferred activities, a lot of people said walking, and yoga is another one, and you all know about yoga for AS is coming up more nicely nowadays. And now, so that's where we thought about what's happening with the pathophysiology in inflammation in axial spondyloarthropathy. What there is we are targeting about is particularly about the immune system, the role of immune system in CD16 positive monocytes. What it is a classical CD14, an intermediate CD14 and CD16, a non-classical CD14 and CD16. These non-classical and the intermediate CD14 attached with the CD16, which is a mediator for inflammatory cytokine. So if we target our exercises and we measure the CD14 or CD16, and so particularly about the intermediate and non-classical monopathways, and we wanted to see how they improve, and then we can say an objective measures of the cytokine level in our patient following exercise. All the study says is a self-reported perception. I do exercise, I feel better, but there's no immunomodulators or immunology was studied on that one. That's what the study which we born, which is called ecstasy study, which is a proof of concept study, which is a randomized controlled study, which is exercise as a therapy for axial spondyloarthropathy intervention, which is we organized before COVID. Unfortunately, COVID stopped it, and after COVID we did it, and we published this paper, and which is in the Rheumatology journal early this year. So our methods are predominantly assessing patient for eligibility. We excluded patients who is not able to participate on exercise program. So we then randomized this patient group into one which can carry on the standard treatment, one which go on do an exercise with the standard treatment, and we looked into any lost follow-up. There is no dropout on this group of patients. And then we analyzed various factors, particularly about the screening and 7-day activity, and then 4-week activity, 8 weeks and 12 weeks. These patients are fitted with a Fitbit sort of an instrument to them, and they do and supervise exercise program, and they go home and they do their exercises. And then we measure the disease activity, physical function, self-reported activities, etc. And this had been either questionnaire-based or anthropometrics, and blood samples, blood pressures, and exercise tests. And we measured the CD16 levels, and particularly about the classical monocytes on the white cell count by doing the flow cytometry, and that's by an immunofluorescent technique we used. And this is a flow cytometry you can see about the CD16 count on that one. What we found, interestingly, those patients doing the moderate to severe exercises are able to manage to do around 6,500 steps, can able to reduce the levels on that one. The interesting thing is none of them drop out. There is no patient had any flare-up of activity of the disease during that conditions. And the disease activity is significantly improved, and the health index has ASAS, and also work productivity is improved, and the p-score of p.0049. And we also looked into the BASFI and spinal pain, which significantly improved with a significant, statistically significant p-value on that one. And we also measured the inflammatory markers, particularly about the CRP and the other monocytes, classical and non-classical monocytes, by immunofluorescent technique, which identified reduced level of these medications, these levels in patients with axial spondyloarthropathy. So in conclusion, what we found is walking can supplement non-steroidal anti-inflammatory therapy to provide an additional anti-inflammatory benefits, and walking can supplement non-steroidal anti-inflammatory therapy to reduce spinal pain. And walking exercise is well tolerated by people with axial spondyloarthropathy. As we can see, there is no dropout of this patient group. So this has been published. So we used a standard patients coming with the standard anti-inflammatory drugs. So we tried to move on, and then we were now got our funding approved, and we got grant, and we got ethics approved to start a randomized control study of patients on biologic therapy for axial spondyloarthropathy, which has been grouped into two, one with a standard biologic treatment and standard of care. Another one is patient with biologic treatment who will be given exercise therapy as an adjuvant, and we measured both the blood test as a case and control, and what we are going to do as well as a cardiometabolic effect on this group, and we are going to come out with the results, because the proof of concept study clearly measures about the cytokine levels are diminished after exercises, and we are going to incorporate on this one and see how best this is helpful. Whereas the biologic therapy can give benefit for 80% of symptom control, and we can add on this treatment, which can also give you more of what we call adjuvant therapy, as exercise and adjuvant therapy for biologic therapy, which can be able to establish treatment more beneficial for our patients. With that, I conclude by thanking my collaborators at the sports medicine at Loughborough University, and also Leicester Biomedical Research Center. And I also thank NAS, which is the National Axial Spondyloarthropathy Society, which gave initial funding for us, and especially to the participants for this randomized first proof of concept study on this theme. And I can be contacted on the email address if you have any questions and concerns. Thank you very much for your observation. Thank you.
Thank you, Professor Murthy. Shall we have discussion at the end after the three talks?
Thank you.
Yeah, Dr. Rajesh.
Yeah, without much delay, we move on to the next topic, emerging drug targets in spondyloarthropathies. We invite Dr. Madheshwaran Mani. Dr. Madheshwaran, I'm really proud to introduce him. He was my former student in Madras Medical College. He's been a gold medalist all through, right from MBBS, MD, and in DM Rheumatology also. He's also been an award winner everywhere. And his assets are his humility, hard work, consistent, hard work, and he's risen up to the post. He was as an assistant professor with me at Sri Ramchandra Medical College for a year, before which he went to Dubai for a few years, and now he's come to his hometown Coimbatore, and he's a consultant rheumatologist at Royal Care Super Speciality Hospital here. Over to you, Madish. I'm so happy to introduce you.
Thank
It's
you,
a
ma'am,
privilege
for the
for
kind
me.
introduction. Welcome all to Coimbatore. So I will mention some of the recent targets, therapeutic targets in spondyloarthropathy. So as we know, like for rheumatoid arthritis, we have multiple options. Like we can, targeted therapy has been evolving, but for spondyloarthritis, we are stuck with like only 3 drugs: TNF blockers, and then IL-17, and then JAK inhibitors. So this is the pathogenesis, so that we can target which domain we can target. So there are 2 things which goes in spondyloarthritis. One is the inflammation. The other thing is the simultaneously osteoproliferation, where there will be fusion of these ligaments for a period of time, leading to the ankylosing changes in the entire spine. So right now, the targets which we have are mostly towards the inflammation, to bring down the inflammation. So the 2 major cytokines, as you know, like TNF blockers and IL-17. So the current drugs available.
What happened? It's not
Just a
moving.
minute, sir, it's okay.
You continue talking from
Slides,
your
slides,
laptop.
find it difficult.
Little more.
It's not moving.
Are you in this slide?
No, ma'am. So from the trials, you can see like we can achieve as 40% response with only 40% with most of the drugs. TNF blockers, if you take across all the maps, so we can achieve like a 40% response with these drugs. So including the IL-17 and as well as the JAK inhibitors. So this is in ankylosing spondylitis. Whereas in a non-surgical SPA also, if you take, we can achieve like 40% response. Only 40% of the patients achieve response with these drugs. So there is a huge unmet needs. So these are the areas where we need to address to have a better quality of life. So with this precision medicine, we can able to, in the following future, where we can take a particular cytokine and we can give that treatment according to that particular inflammatory pathway. So biomarkers, with the evolving things, we can have cytokine signatures, and then we can delineate those patients. The other thing is genetics, with the help of genetics. So these are the few studies which showed like this TNF alpha 308 genotype, if they have better response to TNF blockers. Whereas 857 and TNF 1031, these genotypes are very good predictors of response. So the other upcoming thing is the fecal sampling. So instead of blood sampling, they can do the fecal sampling, and we know the gut microbiome. So this high proportion of Burgdorferi and the fecal samples associated with, it can have a good response to TNF blockers, and Comomonas bacteria abundance shown there is a non-response to TNF blockers, and these E. coli and Shigella species also correlated with the disease activity. So this will be the upcoming future. The other thing is targeting therapy. Like we already have molecules like targeting TNF blockers, interleukin 17, and JAK inhibitors. So we are going to combine these biologics. So right now there is no recommendation to combine the biologics. So, but there are some studies where they did those who have refractory diseases. They have done analysis, and we'll see those in the upcoming slides. And we can combine two biologics, TNF and interleukin 17. The other thing is we can combine biologics with the JAK inhibitors, the small molecules available. So this study from the DDT, that is dual targeted therapy. So data from Spain, they have combined, you can see TNF blockers with the interleukin 12, 23 blockade, and as well as 17, that is secukinumab, and 23, that is ustekinumab. So there are some patients who are on like a Crohn's disease associated with spondyloarthritis also in this category. So this is the data which showed like the spondyloarthritis, that is the ankylosing spondylitis, showed a better response with this combination therapy, whereas psoriatic arthritis, the psoriatic one is the saffron colored, the gray color is the ankylosing spondylitis. So the efficacy they found maximum with the ankylosing spondylitis compared to psoriatic arthritis. So this combination therapy seems to be working, and we need like a controlled studies to see the side effects and other cost factors involved in this. So apart from this, the new biologic agents, the other cytokines which we can target, that is IL-12 and 22, and there is a bispecific antibodies, that is one antibody will target two cytokines, that is the bispecific antibody. So the recently approved bispecific antibody is the bimekizumab. So this it targets interleukin 17A as well as 17F. So it's been recently approved for spondyloarthritis. So you can see the ASAS-40 response. It achieves similar to the other molecules available right now, 40%. And this is the placebo, which they got switched to the therapeutic group, and it also showed a better response. And the sustained efficacy also maintained from, you can see, from nearly like 20 weeks to till 52 weeks. And this BASD, you can see the change from baseline. So initially they tend to have like high disease activity, like more than 4, like 6.7. By week 16, they reduced to like 5.2. And then by week 52, they reached 3.1. So it shows like it has good efficacy, and it's also been approved right now for the ankylosing spondylitis. So the other bispecific antibody is remdolumab, so which targets interleukin, that is 17 as well as TNF alpha. So it got discontinued. The reason is like it doesn't show like any better efficacy compared to adalimumab. So that's the reason there is no add-on benefit with this. So this trial has been discontinued. The other IL-17 blockade is natakinumab. So this also shows like compared to the baseline, the inflammatory markers and the radiographic changes is improved during this ASTRA study. So other IL-17 is brodalumab. This also showed like 40% response in the ASAS category. And the other cytokine is GM-CSF. So this is the Namaste study from UK. Showed like the patient, they had a response similar to the placebo group. So this doesn't show much efficacy, but they are planning to do with the higher doses, which may give up some positive results in the future. So other than that, cell-based therapy, stem cell therapy has been like tried in various diseases. So they're planning to start this cell-based therapy in various trials where they're recruiting, and the reason behind this to repair those inflammatory areas in the spine so that the osteoproliferation can be halted. And this is the gut microbiome. So gut microbiota imbalance leading to leaky gut, and that's been studied in various diseases. So you can see like So before the patient goes for that is FMT, similar to bone marrow transplantation, that is fecal microbiome transplantation. So we need to optimize the donor, and we need to prepare the gut of the donor. So there are a lot of processes involved. It's a very cumbersome antibiotics, so that the gut flora get balanced, and targeting the recipient immune system. So, and this is the area where once the immunity with the immunosuppression, the fecal transplantation will be done. Okay, all right. Next one, next slide. Next, yeah. So this is the recruiting, the ongoing trial. So fecal transplantation is they will take the bacteria from the donor, and it undergoes various processes. So they will make similar to a capsule. So this, what we take as a probiotic, so we'll have this bacteria in the pill, and that will be given to the patient, that is the recipient. So they will ensure they will take serial samples, fecal samples from the recipient to see whether the preferred flora has been taken part in their gut, and then they will assess periodically this activity wise with assess. So this will give us results whether it will be one of the treatment for various diseases. Next slide. Next slide. Okay. So you can see these are the various diseases where fecal microbiota transplantation has been studied till date. So inflammatory diseases spondyloarthritis is one of the important domain, and there are, we can see in Clostridium difficile infection, it's been already established where FMT helps in these patients, and even cardiovascular diseases and liver diseases, cirrhotic diseases. Next. Okay, so we have addressed the inflammation. So these are the important thing which leads to morbidity, that is the osteoproliferation leading to fusion of the spine. So this drug, burosumab, it's been used in X-linked hypophosphatemia, especially in children, where there will be osteoproliferation leading to skeletal deformities. So this drug targets the fibroblast growth factor 23. So thereby, in the recent upcoming years, we'll know whether it helps in the spondyloarthritis. Next slide. Next slide. Okay. So summary, so there is a huge unmet need in spondyloarthropathy. We are stuck with a few drugs compared to rheumatoid arthritis. So the one thing which we can do right now is to combine the already existing drugs, where we can combine the two biologics or biologics with JAK inhibitors. So the future will know whether fecal transplantation will help these patients, and with the precision medicine we can target, we will know that with the genetic signature whether from the day one, we can know whether which treatment helps for this patient, especially the anti-TNF or interleukin 17. So any other cytokine blockade can help these patients. So, but even if the monoclonal antibodies is going to be expensive, the other things which are already on trial. So for a population like in India, so we need a lot of like small molecule research. So where that it can bring down the cost and it serves a lot more patients. So small molecule research is needed in this area, which is the, so thank you.
Thank you, Madesh. Bad luck for you. Your slides were interrupted. Nevertheless, the topic was very good and you gave us a lot of insight. The discussion will be after the next speech. Now it's our turn, a combined turn to invite Dr. Ashish Jacob Matthew from Christian Medical College, Vellore. He was a student all through there and trained under Professor Danda. And he did everything over there. He was a doctorate fellowship, his UG, and then his DM. And he's an international name in GRAPPA, SAS, everything, anything associated with spondyloarthropathy and psoriasis. And he's also in the editorial group in many journals. Over to you, Dr. Ashish, to throw light upon multiomics and pathogenesis of psoriatic arthritis. Let's know what these multiomics are. Maybe a combination of all the omics. Let me see whether we are right. The stage is yours.
As the slide loads, thank you, ma'am, for that kind invitation. You made my responsibility very simple. Yes. You made my responsibility very simple. It is just one statement, multi-omics. It's like multiple omics put together. But unfortunately, we don't have much data, although the technique is just coming up. We don't have much data in terms of psoriatic arthritis. So whatever we have today, I'll just try to summarize in the next few slides, if it opens.
Can you enlighten us ex tempo till the slides are ready?
So, thanks. So what we have when you look at any inflammatory disease or any immune-mediated inflammatory disease, we see that of course, there is a physiological influence, then you have an environmental influence, and if you look at the pyramid, you have a genome over here, a proteome, and then a metabolome. But if you look at the molecules involved in each of these, it's just the opposite thing, because if you have a genome, although you have the base, which is quite wide, you have only 4 bases what we study. As we go up the pyramid, you have proteome, which deals with about 20 amino acids. But if you look at the metabolome, which is metabolomics, you deal with chemicals in the range of 2 into 10 to the power of 5. So the chemical diversity is totally different as we go up the ladder or the pyramid. And that's where this whole thing of multi-omics comes in, because it reveals relevant signal networks. And if you look at this image, we have a number of studies have been doing this. In fact, we have the advances in omics techniques over the years, such as proteomics, we have metabolomics, and computing capabilities have in fact recently enabled us to understand and to have a novel integration of all these techniques together. So if you look at the inner circle, it's all the omics, and then the outer circle is the non-omics, which includes, in fact, I think somebody was asking me what is radiomics. In fact, you have imaging there, you have things like wearables. So all these things put together, we get into a machine learning model, which can be unsupervised or a supervised model. And that leads us in helping disease risk prediction. We have disease subphenotyping, molecular insights, biomarker discovery, as well as response to treatment. So that's where we are headed in terms of the whole landscape of multi-omics. So what can be done in terms of psoriatic disease? Now, there are very few window we have in terms of psoriatic disease. We need to understand the quest for biomarkers for early identification of the disease. What are the biomarkers which can predict, in fact, progression from psoriasis to psoriatic arthritis? The therapeutic discovery has been going on since 1990s, and we know that the decisions what we have today, much of it is based on what we feel, because if you look at the trials, but for the skin, if you look at the skin, of course, there is a difference between IL-17s and TNF inhibitors, but for that, I think it's pretty much the same in terms of effectiveness. So what can be done in that realm? And prediction and monitoring of therapeutic responses during chronic stage of the chronic disease stage. So these are the things which we can use for multi-omics in psoriatic disease. And when we look at whatever studies we have from, actually there are two groups working on this. One is the Oliver Fitzgerald's group in Dublin, and then Vinod Chandran's group in Toronto have been kind of into omics for the past few decades. So starting with genomics, they went into transcriptomics, and now into metabolomics. So this is what, again, the samples what we can take from can be from the synovium, from the skin, from the peripheral blood, and from the urine. I'll come to it in a bit of a detail as we deal with proteomics. And essentially, like what I mentioned earlier, it has given a good understanding of pathophysiology, risk prediction from psoriasis to psoriatic arthritis, diagnosis, and prediction of response for treatment. Now, genomics is essentially, it identifies and characterizes the genes and alleles associated with psoriatic disease. We do have susceptibility loci associated with psoriasis and psoriatic arthritis alone, and we have the psoriatic arthritis, which is more in terms of the HLA-B alleles and IL-23 receptors. So you have the pathological gene variant, which assists diagnosis, and at the same time it helps in prediction of onset, severity, and likely symptoms of the disease. Now, the genes distinguishing psoriasis and psoriatic arthritis are basically pretty much the same. Many of them are same with other diseases, other inflammatory diseases, including axial spondyloarthritis and rheumatoid arthritis. So it's very, very little we have out there in terms of specifics when you talk about genomics for psoriatic arthritis itself. And of course, we've been having these genome-wide association studies, genome-wide genotyping assays, which have been helpful in getting us to what our current understanding of the disease is. So when you talk about a typical genome-wide loci, it usually consists of many variants in high linkage disequilibrium, and frequently far away from any of the genes, and that is what makes the interpretation more challenging. But it's kind of possible to use a combination of functional genomes, which can include chromatin activity. There's something called EQ, TLs, and chromatin conformation, which leads us to understand or to tease out these differences and to move on. So this is what we have in terms of the chromosome. This is pretty much the same, which has been there for a couple of decades now. We know that HLA alleles are the most important ones when it comes to genomes. We do have PTN
PTPN22, which is common for rheumatoid as well. We have TNFAIP3. So all these things there's a bit of common genes running through these immune-mediated inflammatory diseases right across the board. So in terms of genomics, there's nothing much except for understanding the pathway involved. If you look at the HLA, we know that it's included in antigen presentation. We have TNIP1, we have TNFAIP3, which is mostly for NF-kappa B signaling. The PTPN22 is again for IFN1 and IFN2 pathway. We have IL-12B, which is Th1 signaling, and then which is, I would say, closer to the IMIDs, which is immune-mediated inflammatory diseases, would be the IL-23 receptor or the IL-23 Th17 pathway, which is more closer towards PSA part. So we do have specific gene polymorphisms, which teaches in terms of additional risk for PSA progression. And of course, genome sequencing technology and machine learning techniques and functional correlations of GWAS variants can be looked into. Moving on to transcriptomics, which is essentially understanding the gene expression studies. We have microarrays, which have been useful for this technique, which can be done in peripheral blood, in skin, as well as in synovial fluid. We have this particular study, which in fact, these are very few studies which have shown, this one particularly showed a dysregulation of the T cell activation and the B cell activation and MAP kinase pathway, which was seen in peripheral blood. We have similar studies in synovium, which helped us to understand Th17 response better because it helped us to understand the upregulation part. And then in skin itself, again, Th17 pathway. So we did have these studies earlier, but these are new studies which have shown mostly from the synovium and the skin, which seem to be giving better yield as compared to peripheral blood about transcriptomics. Now, after this came in the proteomics and the metabolomics, which has kind of changed the landscape of this whole thing, more in terms of discovery of biomarkers as well as better understanding of pathogenesis and for candidate biomarkers. So the methods would include elementary immunoassays to high throughput MS, which is mass spectrometry based assays. These potential biomarkers like what I mentioned, and coexisting factors in peripheral blood interfere with candidate soluble biomarkers. We do have in synovial fluid and the skin as well. So psoriasis and psoriatic arthritis, in fact, share a serum proteomic signature. This is one of the latest studies which has shown the sharing bit between PSA and psoriasis, which can lead to the belief that, that it could be a single disease spectrum than different entities altogether. Now, this is a figure which just shows about what each of these things are. Now, if you look at the serum, although it's easy easy availability as well as less invasive, we know that it's not one of the best for proteomics. So people have gone back to synovial fluid and skin biopsies, and these are the few biomarkers what we have from the synovial fluid, which includes MPO, there is H2AFX, PFN1, MMP3, S100A9. So these were mostly from the synovial fluid, and then we have from the biomarkers from the skin biopsy, which included ITGB5 and POSTN. Coming to metabolomics, this is one of the most exciting things of late because it basically gives a snapshot of the physiological status rather than what is going to predict the disease, like what you have for genomics as well as transcriptomics. And in fact, one of the good things about metabolomics or metabolites is essentially it's a changing, it constantly changes. It's not like genome, which you have, there is an unchanging genome and a transcriptome, but you have a metabolite which keeps changing, and that kind of gives our ability to have a snapshot. And it's basically a reflection of the intersection of genome with environment and microbiome. And again, an organism's metabolome, actually, if you look at it, is the most reflective of the observable phenotype of that organism. So we have a biological question from where there's an experimental design, sample preparation. So these are the steps involved in the metabolomics. If you look at, there can be a targeted metabolomics as well as untargeted metabolomics. And most of the times you have the untargeted ones are more tedious because the sample preparation is a major problem in that part of in the process, and we need to have good technology which is mostly MS, which could be MS, or it could be for separation, sample separation. We generally use mass spectrometry, or in fact we can use other techniques which can also, in fact, something like gas chromatography and mass spectrometry over here. But most of the robust ones have been using LC-MS technology for that. And these are mostly few studies. Most of the studies have been in psoriasis domain, and we do have studies coming off late in psoriatic arthritis as well. But there's more to understand in terms of metabolomics in psoriatic arthritis as of today. So this is what we're talking about all this while. We have on the left, or to your left, you have the targeted molecules, and then the typical approaches, and then you have the multi-omics regime where you have each of these taken separately, but it can integrate between each of these. Need not be all four across, but most of the studies have integrated genomics and transcriptomics, and there are a few studies which have actually looked into proteomics and metabolomics in this domain. So this I would like to skip in the interest of time. Essentially, it's the same thing which gives a snapshot of what are the molecules, what we have, or what are the cytokines, what we have in each of these domains, both in synovium, peripheral blood, as well as skin, through multi-omics techniques. So this, again, there's one step ahead, was a single cell omics, which again is pretty much the same, but the advantages over here is basically it increases the power exponentially, both for diagnosis as well as prognosis. And like what I mentioned, genomics and transcriptomics have been combined for a few studies, and so have been metabolomics and lipidomic analysis. This is one of the recent studies in which they combined metabolomics and lipidomics, and the combination of bile conjugate glycodeoxycholic acid sulfate and lipid mediator lycotrine B4 were sensitive and specific for prediction of progression from psoriasis to psoriatic arthritis. So what are the challenges we have in terms of specific for psoriatic disease itself? First one is defining phenotypes, because we know that it's difficult to actually define a phenotype of psoriatic arthritis, and that's why we need integration of imaging, because we do have a lot of imaging studies which show subclinical arthritis or synovitis or in fact enthesitis. Biological sample can be serum or plasma. It's not always the best, so we need to dig into biopsies or to more invasive procedures like synovial biopsies. Differential therapeutic response for each clinical domain. We know that in case of psoriatic arthritis. Then we know that comorbidities are pretty much common with all these diseases, and that's when an overlap of metabolites can be a problem in these diseases. And of course, we know that the immune-mediated inflammatory disease concept is an intertwined one, because you have IBDs, you have uveitis, everything put together. So there can be a lot of noise when you talk in terms of predictive factors. And other challenges include cost, availability of platforms, interpretation, and expertise in machine learning. Thank you very much for your kind attention.
Thank you, Dr. Ashish. Now the session is open for questions from the platform. Maybe when somebody is getting ready, I can start off with one or two questions. First one addressed to Dr. Armugamurthy. Sir, we would like to know whether exercises alone are enough for mild spondyloarthropathy instead of NSAIDs and DMARDs in the early stage. Can't hear you, sir.
Mic, please.
Thank you, madam. In early stages, exercise alone can be able to reduce the cytokine and inflammation on that one. In established cases, we can able to improve the benefit of non-steroidal anti-inflammatory drugs by patients doing some exercise. In more advanced patients, then the biologic therapy plus an adjuvant therapy as an exercise may be beneficial, but we are trying to get that concept clear by doing our research, which is ongoing from September. Thank you.
Thank you. The next question is addressed to Dr. Madheshwaran. You mentioned about fecal transplant. I think fecal transplant died a slow death by itself. As far as the gut microbiome is concerned, no therapy.
Yes, ma'am.
Madhesh, to you only.
Yes, ma'am.
About fecal transplant. The success rate of fecal transplant.
It's, right now they are recruiting them from small other, especially for the Clostridium difficile infection. They found like a very good response.
Okay, and Ashish, I think I passed in the exam, no, about my answer on multiomics. Okay. Yes, John, Venugopal.
Two things. First question to Dr. Arumurthy.
Actually,
how do you have complaints for exercise with spondyloarthritis patients? Generally, our spondyloarthritis patients, when we ask to do exercise, they listen there, but most of the patients end up not doing. So how do you improve the compliance? That's first. Second is to Madheshwaran. Actually, I am really scared to combine TNF5s with JAK inhibitors. Really, really scared. Because in a country like, he showed one Spanish patient which they tried it out, but combining biologicals and JAK inhibitors, maybe, but be very, very, very careful.
Thank you, John. I agree with you. The compliance in patients, educating patients on exercise is a bit difficult. And in our clinical practice, we started using with the specialist nurses to educate and motivate them to exercise. And then coming back into exercise and how they are adhering to the exercise, that can be only monitored by your Fitbit, etc., where they can able to say. At the same time, we can measure their blood test. So unless otherwise we show some objective evidence, scientifically there is an improvement in cytokine levels or CRP inflammation down, patient may not be able to do that unless they see the benefit. So that's what we are trying to prove that as a non-pharmacologic intervention for axial spondyloarthritis. Thank you.
Dr. Venugopal? Yeah. Oh, Madhesh, you're going to give the answer. Okay.
Sir, as you said, like it's difficult in our country, especially where there is a JAK inhibitor use even without screening for viral markers. So combining both together, so we need control studies to see whether there is an add-on infections, and also the financial things. Everything has to be taken into account.
Yeah. 1 minute. What about role for probiotics? You said about fecal transplant to change the microbiota. No? So is there a role for giving regular probiotics orally in SPA
that has been tried, sir, but no definite improvement in the disease symptoms. So that is why the entire flora microbiota has to be reset, so that the bacterial, what the proposed pathogenesis is, this bacterial proteins from the gut get into the blood. This pathogenic strains gives the peptides, so that is how the immune system gets activated. So we need to reduce those pathogenic strains, the proteins, the bacterial peptides. That is how the fecal transplantation helps.
Dr. Murthy, what about physiotherapy? Are you separating physiotherapy and exercise, or are you doing a combination?
No. Physiotherapy is mainly about stretching exercises as per the NAS guidelines or the BARC guidelines which are doing. This is patients, we encourage them to do a brisk walking so that it can improve the physical capacity, as also improve the cardiometabolic. At the same time, it improve the inflammatory effect on them. So it's just an exercise.
Yeah, apart from the
Excellent.
Mahendranath, sir.
Through the chairman to Armugam Murthy again. Even in early stages, Murthy, I have been teaching exercises personally and brisk walking 30 to 45 minutes a day, 5 days in a week at least to patients. It's impossible to convince patient if you don't give a prescription, even a placebo tablets. It may be possible in United Kingdom, but definitely not possible. People, if you come and see you, they pay a huge fee and say, go and do an exercise. They don't accept it, you see. They don't accept it. It will take a long time to make them aware.
Yeah, I agree with you. I mean, obviously, there are two issues on that one. The patient is not keen to do that because they don't see the immediate benefit out of that. And second thing is the physical disability which they already have may not allow them to do that. That's the second possibility. I agree that even in England, we are struggling to educate patients to do an active exercises. And last month, we asked questionnaires to our patients in my clinic, how often you do exercise. The first question they said was, how many doctors told us to do exercise regarding the ankylosing spondylitis. So the problem lies in both sides. At the same time, what we are not able to give them a litmus test for them to say that this is the fruit of the pudding, then they will be able to do that. And it's a challenge which we are able to address on that as a non-pharmacological intervention for this condition. Thank you.
Any more questions from the juniors? Yeah, please.
I have a question to Dr. Ashish regarding the metabolomic studies. The metabolomics change with the therapy, if I understand it correctly. So is it necessary to take patients who are treatment naive? And then that becomes a challenge in tertiary care settings because most of the patients would have already received DMARDs or biologicals by the time they come to us. So is it necessary to select treatment naive patients when you're planning metabolomic studies?
Yeah, it's a good question. Like what I was talking about, the issues with metabolomics, one of them is the lot of noise in terms of what exactly you want, but it again depends on the question, right? I mean, like, so your question should be pretty clear in terms of what exactly you're looking at. And if you're looking at a particular, like what you're saying, predictive response, then probably of course take patients who are naive to treatment.
Any juniors, postgraduates? Nothing, very clear. Okay, we thank all of you for your, sir is telling all of you understood very well, so he's appreciating you all. Okay. Thank you all very much, all three of you, for your wonderful deliberations. And thank you, organizers, including me, for giving me the chance to chair this session. I think we have to do the honors for the
Request the
speakers.
chairpersons to present the mementos
Thank
to
you.
the speakers.
You can give a very good claps for the speakers.
I request Dr. Armugamurthy sir to present the memento to Dr. Rajeshwari ma'am.
So we request you to give a very good applause for the chairpersons too.
I request Dr. Ashish Jacob Matthew sir to present the memento to Dr. U.R.K. Rao sir.
Thank you, chairpersons, and thank you so much, speakers. And kind attention. So all delegates and faculty should sign the register in SZIRACON stall for MCI credit points every morning and evening. Please, we request everyone to make a note of it. And now we are going to disperse the session for a small stretch break. So we request everyone to gather here after 10 minutes. All in charge to take over the session 3.
Moving on to third session. This session will be chaired by Dr. K.M. Mahendranath sir. He is currently consultant rheumatologist in Samarpan Rheumatology and Arthritis Center in Bangalore. And Dr. Purkodi ma'am, she is currently a consultant rheumatologist at Kamakshi Memorial Hospital in Chennai. I welcome the chief chairpersons to come to the stage to chair the session.
Welcome back to the session. I think the next topic is autoantibodies in IAM, clinical implication. The speaker is Dr. Vishnu Chandran, HOD and Associate Professor, Department of Rheumatology, Believers Church Medical College, Tiruvalla, Kerala. His areas of interest are inflammatory arthritis, fibromyalgia, CTD, ILD. I look forward for his talk.
Thank you, chairpersons. First of all, let me thank the organizing team for giving me this opportunity to present on autoantibodies in idiopathic inflammatory myositis. The objectives of my presentation are to understand the subtypes of myositis, to recognize the importance of antibodies in inflammatory myositis, and comprehend the clinical associations and complications, and gain insight on diagnostic tool, treatment approaches, etc. To look into the inflammatory myositis, we know that it is divided into mainly dermatomyositis, inclusion body myositis, and polymyositis. Polymyositis is largely then divided into the newer immune-mediated necrotizing myositis and the antisynthetase syndrome, and newer subgroups have also come up like cancer-associated myositis, overlap myositis, where systemic connective tissue disorders are also involved. And the autoantibodies that are exclusive in myositis are called as the myositis-specific antibodies, and those which are associated with overlap myositis or other connective tissue disorders are called as the myositis-associated antibodies. We know that antisynthetase syndrome is the most common phenotype that is well described in the literature, and it is characterized by the anti-Jo1 antibodies. Even though anti-Jo1 is well known for antisynthetase syndrome, other antibodies like the PL7, PL12, EJ, OJ, KS, HA, and ZO are associated with antisynthetase syndrome. The classical presentation includes fever, rash, interstitial lung disease, arthritis, and mechanics hand. But most often, the clinical presentation is incomplete, and many of the patients will be diagnosed as CTD-associated ILDs or inflammatory arthritis in the beginning phase. The classification is into the polymyositis group, but it is also, it shows features like skin rashes and mechanics hand, which is again a feature of dermatomyositis. And also the histopathological features fits into the dermatomyositis group, and hence the diagnosis of antisynthetase syndrome is made. We know that myositis is more common in Jo1 and is also in other antibodies like the PL7, EJ antibodies. Arthritis is more common in Jovan antibody, and interstitial lung diseases are common with PL7, KS, OJ, and PL12. In patients with PL7 antibody positivity, sometimes the interstitial lung disease precedes the onset of myositis, and they have pericardial involvement also. The OJ antibodies are associated with severe myopathies and lower incidence of Raynaud's phenomenon compared to that of other antibodies. And the presence of these antibodies in juvenile dermatomyositis are very rare, and it is found in less than 5% of the patients. Now, we know that dermatomyositis is characterized by the classical skin manifestations, especially the Gottron sign, the Gottron papules, heliotrophic rash, Scholl sign, V sign, etc. But it is also a multi-system disease where organs like the pulmonary system, the peripheral vascular system, cardiovascular system, and gastrointestinal system are seen in addition to the muscle and the skin involvement. Many antibodies have been associated, and these antibodies have shown to have some common features like dysphagia, involvement of malignancies in these diseases, calcinosis in children, especially with the NXP2 antibodies, cutaneous ulcerations, the presence of classical heliotrophic rash, Scholl sign, more specificity, more involvement of skin with certain antibodies. I'll come into details of these antibodies in the coming slides. Immune-mediated necrotizing myopathy or myositis is characterized by the association with statins and the antibodies to the anti-HMJ-CoA reductase enzymes and anti-SRP antibodies. So these antibodies are very important because in special conditions like anti-SRP antibodies, there is a high propensity for cardiovascular involvement, and the necrotizing myositis itself is a very deadly disease with the skin being least involved and the muscle being most involved. The myositis is more severe and rapidly progressive in some cases and resistant to conventional immunosuppressive therapy. Anti-SRP is one of such antibodies which will predict the prognosis. Dysphagia and cardiac involvement are the most common dreaded complications. ILD is very important in these patients, and occasionally they are misdiagnosed as muscular dystrophy. And muscle biopsies are important in these patients to distinguish from muscular dystrophies. It is rare in juvenile dermatomyositis and the adult group, but as with the adult group, this group is found to have a more refractory disease, and the treatment approach should be more aggressive. Now, anti-HMG-CoA reductase enzyme antibodies are associated with statin-associated immune-mediated necrotizing myositis. This is seen in nearly 40 to 60% of the patients, and these patients are prone to have a good response with treatment and statin withdrawal. However, patients who are statin naive, these patients have a more refractory stage of disease, and aggressive immunosuppressive therapy is mandatory. Next, coming to the cancer-associated myositis, the definition is the involvement of malignancy in within the 3 years of onset of myositis, and it is seen more in the adult myositis than in the juvenile onset myositis. The high-risk population includes those which are associated with the TIF1 gamma, TIF1 alpha, NXP2 antibodies. Various organs like lung, ovarian, colorectal, lymphomas, breast, and nasopharyngeal cancers are seen in association with these antibodies. These antibodies are seen in nearly 50% of the adult patients with associated malignancies. The risk increases with age, and it is not commonly seen in children, even though the antibodies are present in the juvenile dermatomyositis. The combination of both TIF1 gamma and alpha together, which is found by the immunoprecipitation techniques, are shown to have more propensity for malignancies, and NXP2 is a rare autoantibody that is seen in cancer-associated myositis when compared to the juvenile population. In the juvenile population, these patients are with NXP2 are found to have more of calcinosis and less risk of malignancy when compared to the adult, whereas TIF1 gamma is found to have more severe rashes, blistering and necrosis seen on the skin, pruritus, subcutaneous edema, and lipodystrophy. So coming to the importance of these antibodies, it is very important to risk stratify the patients into the high risk, intermediate risk, and low risk patients. And in patients, especially who are having adult onset immune mediated necrotic myositis. The dermatomyositis subgroup is most commonly found to have antibody with high risk, like TIF1 gamma and NXP2, and as the age more than 40 is found to have more propensity for malignancies. These patients have more cutaneous necrosis, dysphagia as clinical presentations. Even though antibodies like MI2 was initially classified as less risk, now is considered as intermediate risk along with other antibodies like SAE, HMG coreductase, and MDA5, especially when they are not using statins. The screening, with screening, we have to stratify it as low risk or high risk or intermediate risk, and basic screening strategies with comprehensive history, physical examination, blood, and other parameters are mandatory, and enhanced panel with imaging and workup for ovarian, nasopharyngeal, and invasive techniques for nasopharyngeal screening is mandatory for such patients. Interstitial lung disease is another most common important complication of dermatomyositis, and it is seen to be rapidly involved in patients who are having anti-synthetic antibodies, PMSCL, anti-SEA, and anti-MDA5 antibodies. The propensity for a rapid progression of ILD is more with anti-MDA5, and it is associated with high mortality. When compared to anti-synthetic antibodies, especially the PL7, PL12 antibodies, these are found to have more severe ILD than the anti-Jo1, and it is more common in the Asian population. The longer the delay for diagnosis of anti-synthetic syndrome, there is a more risk for developing interstitial lung disease. Anti-MDA5 is the one which has least of the muscle involvement and more of interstitial lung involvement in patients, especially who are of Asian origin and that to East Asian origin. And nearly 81% of the patients have amyopathic presentation with a rapid progression in nearly 74. Diffuse alveolar damage is seen in these patients with a high mortality rates, and it is affected in the childhood patients with juvenile dermatomyositis in Japan. And they have a similar presentation even in the juvenile dermatomyositis group, and cutaneous ulcerations are seen in these patients, and they also have a propensity for vascular injury, and this cutaneous ulceration reflect the endothelial damage. Then clinically amyopathic dermatomyositis or CADM is associated with the MDA5 and anti-SAE antibodies, and they also have a rapid propensity for ILD formation. The anti-SAE and anti-MDA5 differs with the skin ulcerations, mechanics, and polyarthritis, and rapidity of lung involvement. The myositis may develop in anti-SAE antibodies in the later stage, but not in the MDA5 most often. And malignancy is common with the anti-SAE antibodies. So to sum up, the skin and the muscle involvement are seen in dermatomyositis, and the more propensity for malignancies have been found in patients who are having both skin and muscle involvement together, whereas the less propensity is seen in the ones with without skin manifestations. Now, juvenile dermatomyositis, nearly 60% of children have autoantibody positivity, and anti-TIF1 gamma, NXP2, MDA5 antibodies are seen in nearly 50% of these patients. And there is less risk of malignancy when compared to the adult population. There are severe cutaneous manifestation and chronic disease course with TIF1 gamma patients. Calcinosis is more common with NXP2. Skin rashes are seen with other antibodies also, especially the anti-SRP and anti-HMG coreductase antibodies. The inclusion body myositis is another subgroup where there is more propensity for men in the older age group, and they also have an autoantibody, that is the cytosolic 5-nucleotidase 1 antibody found in nearly 30 to 50% of patients with IBM. But these autoantibodies are found in other connective tissue disorders like Sjogren's syndromes. And the classical presentation will be that of proximal distal muscle involvement along with the finger flexors involvement in these patients with biopsy showing rimmed vacuoles, eosinophilic cytoplasmic infiltrates, inclusion bodies, and it will be a delayed diagnosis and mostly initially diagnosed as polymyositis. So these autoantibodies have certain genetic susceptibilities also, especially the ones with HLA-DRB1 in Asian population, and strong propensity for antisynthetase syndrome, MDA5 related interstitial lung disease, and the TIF1 gamma with HLA-DQA antibodies genotypes. The environmental interactions, especially we know that the statin can trigger immune-mediated necrotizing myositis, especially with the anti-HMG co-reductase antibodies, and statins as well as statin-containing foods like oysters, mushrooms, red yeast, rice, and tea should be avoided in such patients. Those patients who are having a high propensity for skin involvement, UV radiation should be avoided, and smoking should be avoided for preventing interstitial lung disease. The technique of choice for detection of these antibodies include immunoprecipitation, but ELISA is commonly used. ELISA and line assays are commonly used in our population due to the cost issues. Anti-nuclear antibody staining also helps in diagnosing these patients, and especially the spectral pattern with the U1RNP, fine spectral pattern with the MI2, etc., etc. Now, how will this help in treating these patients, especially avoiding statins, exposure risk prevention, as well as helping in aggressive treatment in patients who are having specific MSAs like that of anti-MDA5, anti-SRP, anti-HMG co-reductase antibodies, and cancer prevention in patients who are having TIF1 gamma and alpha involvement. The refractory patient should be treated more aggressively with rituximab, cyclophosphamide-like treatment, and IVIG in certain patients, and biologic therapy with abatacept, anakinra, etc. should also be used. So to summarize, the myositis spectrum is diverse with various antibodies which helps in the early diagnosis. Importance of early and accurate detection is important. Genetic and environmental influence should also be taken into consideration when treating these patients. And the personalized treatment and management should be given. So the take-home message is that autoantibodies in idiopathic myositis are not just markers for the disease. They are the key to unlocking the diverse mechanisms to drive the complex condition. Understanding the biomarkers offer a path towards a personalized and more effective treatment, transforming how we approach our patient care. Thank you.
Thank you, Vishnu, for the excellent elucidation of questions we can take later. Or? Yeah.
Next, I invite Dr. Ashwin Nair to give his talk on RNase therapy in lupus. He did his MBBS and MD from Kasturba Medical College, and his postdoctoral fellow and DM in rheumatology from Christian Medical College, and is at present a senior consultant rheumatologist in Travancore Medical College Hospital, Kollam. And his other qualifications are Specialty Certificate in Rheumatology, Royal College of Physicians, United Kingdom, completed basic and intermediate level training in musculoskeletal ultrasound, and Fellow of the Academy of General Education, Manipal, Karnataka. He's published 23 papers in national and international journals, and has received a grant from the Indian Rheumatology Association for the year 2016 to 2017, and APLA Research Grant in 2021. His special interests are early inflammatory arthritis, inflammatory myositis, and musculoskeletal ultrasound. Over to Dr. Ashwin.
Thank you for your kind words, Madam. At the outset, I would like to thank the organizers, the chairpersons, Mahendranath Sir, Pokadi Madam, and the whole SZIRACON team for giving me this opportunity to stand in front of this august audience today. Well, today we are changing gear to SLE and what are the current treatments and some of the newer which are available for lupus. Well, our armamentarium for the treatment of lupus is increasing, and as we all know, anifrolumab and voclosporin have got FDA approval. And so, other than for the conventional treatment of hydroxychloroquine, steroids, use of DMARDs, immunomodulators like cyclophosphamide, mycophenolate mofetil, azathioprine, we have the biologicals and the small molecules also. So we have, like the previous speakers had said, we have B-cell targeted agents. Now we have the BiTEs coming, the interleukin inhibitors. So we have several interleukin inhibitors which have been tried in lupus, interferon inhibitors, and that's where all the now focus is on SLE being an interferon signature disease. Will interferon inhibitors be all in all cure for the various heterogeneous manifestations of lupus and JAK inhibitors? Now, let's just retreat to what exactly do we see in lupus. In lupus, we have antibodies against nucleic acids and nucleic acid binding proteins. So we have antibodies against chromatin, histones, dsDNA, and also the RNA binding proteins. Now, like I said, SLE was supposed to be the prototypical interferon signature disease. But I think this is a paper which all of us have to look into, which basically looked at the different types of interferon which is seen in patients with lupus. And if you can see, all the different subclasses, type 1, type 2, type 3 interferons are seen in lupus patients. And that's where the drawback of probably drugs like anifrolumab lies. Anifrolumab, which is a type 1 receptor antibody, may not be sufficient for those who are expressing high levels of interferon 2 or interferon 3. Like what this paper from Japan says is that certain clinical manifestations are also quite specific for the interferon signature. Like for example, if you, I'm sorry for this thing, but if you look at the skin manifestations, it's predominantly type 1 interferon, and that is what the studies with anifrolumab showed. But if you take lupus nephritis patients, these patients had secretion of high levels of type 1, type 2, and type 3. So just focusing on type 1 may not be enough for these patients with this signature. And even the interferon signatures, the gene being expressed is also very different. So interferon may not be the overall answer, but yes, in our armamentarium, it may be quite beneficial. So let's go one step above. Before interferons are basically produced, what stimulates these interferons? And that probably is dsDNA, and another one being RNA, and being the topic of today's discussion. So we have several types of RNA in circulation. We have messenger RNAs, and we have several non-coding RNAs all circulating in our bloodstream, probably evading the immune system. So what happens, why aren't all these RNAs stimulating our immune system? That's basically because in healthy individuals, we have the very effective clearance mechanism by the RNAs activating. But in lupus, what happens is, since there's a lot of apoptotic cellular debris, these endonucleases get overwhelmed, and so there is an inefficient clearance of RNA by these RNases. And not only that, we all are aware of autoantibodies, particularly RNP, ROS, LA. These are basically antibodies against antigens containing RNA, and they act as a vehicle for stimulating downstream immune regulatory pathways. Like for example, I've taken the example of the structure of the U1 RNP. If you look at the U1 RNP, right in the center, you have U1 RNA. It's this U1 RNA which stabilizes the whole RNP molecule. And if you can destabilize that one RNA, or basically lyse that RNA, that whole compound becomes, or that whole protein just disintegrates. And that's basically what was, that's where the initial work started in 2016, where they found that patients with lupus and not rheumatoid arthritis patients showed elevated levels of antibody bound to U1 and Y1 RNA, to which Rho62 gets attached to. In about 228 patients, what they found is that this abundance of RNA-bound antibodies correlated with disease activity, and it also correlated with the interferon signature. So stating that RNA is driving interferon pathways and disease activity in lupus. So why not target these? So before we go into why not target this, what exactly happens? How does RNA stimulate? And what happens? These autoantibodies, they act as a vehicular system and delivers these RNA to the intracellular compartment and activates the TLR7 pathways, and it's predominantly the toll-like receptors. So if you look at the DNA is basically stimulates the cGAS and the STING pathway. RNAs activate the RIG and the MDA5, which Vishnu had already spoken to, but the RIG and the MDA5 being intracellular RNA sensors, it activates MAVs, which I'll come to in some time. But our focus is basically what happens is there's a lot of immune complexes in SLE, and this immune complex is is endocytosed, is presented to the endosome, and it basically is presented to TLR7, 8, 9, and 3, where predominantly they get stimulated by the double-stranded RNA and the single-stranded RNA, and that through downstream pathways releases both interferon alpha and beta as opposed to just DNA and RNA alone. So what is the RNA TLR toll-like receptor relevance? So we all know TLR7 is very important in the pathogenesis of lupus. More than TLR9, it is TLR7 which basically runs the pathogenic mechanism in lupus. It is solely required. It's basically solely required for accelerated autoimmunity, and RNA is a primary target for interferon pathways and downstream activation of IRF3 downstream, causing production of both interferon alpha and beta. Now, is it just TLR7 activation? Probably not, and this was an earlier study which was done in 2015, where they saw that anti-insulin antibodies basically triggered B-cell autoantibody, created a mild increase in plasmablast and immune complexes. But when you put in ribonucleoprotein, which acts on both the B-cell receptor as well as on the TLR7, there's an augmented response, and it increases the plasmablast production as well as immune complexes, IgG production is markedly elevated. So RNA basically has dual action on the stimulation. Let me come back to MAVS, that is the mitochondrial antiviral signaling protein. Now this protein is very interesting because it basically on activation it undergoes a prion-like aggregation and self-propagates the activation signal of a viral RNA and just keeps on producing interferons. So this was a paper where, again in 2016, which showed that MAVS aggregate positive lupus had higher levels of serum levels of interferon beta, and these patients had an increased association with autoantibodies, that is Smith and UNRMP, saying that there is a role for RNA containing autoantibodies in the pathogenesis of lupus. So as we know, it is not only through the toll-like receptor pathway or the B-cell receptors, you have Fc gamma receptor activation also on plasmablasts, which triggers not plasmablasts, on the dendritic cells, within the plasmacyte or dendritic cells, which increases again the interferon alpha levels. So all these put together, shouldn't we target RNAs? So shouldn't we get in RNases to target, and that's where this particular protein comes. So just before I go to the compound, there are not only this a cleaning function of RNases. RNases have several innate functions. It has function on the cellular immune regulation, on the epithelial barrier protection. It is involved in tissue homeostasis, repair, and remodeling, and several other features. So if you are giving RNases, will it affect all these things is basically what we have to see in the ensuing studies. So like I said, this is what the compound is all about, and that is the figure which you saw on my title slide. This is RSLV 132, which is basically RNase A family, RNase 1 family RNase, which was fused to the amino terminus end of an Fc domain of a human IgG1. It can be given intravenously. Its half-life is approximately 90 days, and so ideally 1 monthly dosing is more than enough. Its safety study came way back in 2016, which again was a multicenter 1B study, which showed this compound had demonstrated excellent safety profile. So this is why probably I'm standing in front of you. This is a study which came out this year in lupus, wherein they evaluated RNase therapy, which is a phase 2A trial, again a randomized placebo-controlled trial, wherein patients satisfying the ACR criteria for lupus more than 17 years of age with moderate to severe cutaneous disease, that is a CLASI score of anywhere more than or equal to 10, could be enrolled into the study, provided they had they remain stable on the stable dose of the medications over the last 30 days prior to baseline. Now, 65 patients were initially recruited, but one removed the consent, so it was 64 patients. The primary objective was to look at the change in the CLASI score at days 85 and 169, and they also had secondary objectives looking at change in the patient global assessment, SLEDAI scores, BILAG, and from these, BICLA and SRI-4 responses were calculated, and they also looked at a 50% improvement in CLASI score. Baseline parameters were more or less same, but only thing is that the RSLV3, if you look at them, they had both the groups, the SLEDAI 2K scores had somewhere around mean of 2. They had lesser anti-dsDNA, anti-Rho, anti-La antibodies, few numerical differences between both the groups, etc. But what I want to highlight is the patients recruited in the study, and probably one of, I won't say pitfall of the study would be that these patients were not very active. There were patients with a SLEDAI of 3 who were recruited into the study, 3 and 2 which were recruited into this study. The results were that there was no significant difference in the CLASI score, SLEDAI 2K, physician global assessment, or the BILAG score. Probably had to do something with the recruitment strategy, but so neither of the primary or the secondary objectives had come into. But when we look at numerically, they did a subgroup analysis taking patients with high baseline scores, that is SLEDAI score of more than or equal to 9 or a CLASI score of more than or equal to 21, and now we see a response. We see a response that they had an increased SLEDAI, those patients with high SLEDAI had an increased high frequency of SRI-4 response, BICLA response, and also the CLASI response. And none of these patients had developed autoantibodies. Pitfalls, which I already told you, and the adverse events were not very severe. The adverse events, which was treatment emergent adverse event, were infusion reactions and a generalized pruritus, but there was only one serious adverse event which mandated hospitalization, which was a hyperesthesia, which a patient complained of on the last day of infusion. So basically, to sum up, we can use this therapy for patients with high seems like we can use these patients for a high baseline SLEDAI or a CLASI score. But there are other studies which are showing incomplete chromosomal inactivation, which basically causes an increased dosage or increased levels of TLR7. Can we use, this therapy in those patients? Probably because these patients are most sensitive to circulating extracellular RNA, and so this may be one of the candidates for this RNase therapy. Now, there's something else which we have to bear in mind, and this was another very interesting study from Japan, and which basically tells us how heterogeneous the conditions like SLE and Sjogren's are. Now, when you use RNase therapy for a patient on U1-RMP, like I showed you before, you are dislodging that central U1 RNA, and so the whole compound gets disrupted, the immune complex formation gets reduced. But that is not the case when you give it to a patient with predominant Rho or La antibody, which are basically bound to the Y RNA. So what happens if you dislodge the RNA from these, you're exposing sites for other autoantibodies to come and get attached, and probably enhancing Fc gamma receptor activation and increasing the immune complex response. So probably we might be seeing more personalized medicine which is coming into play, probably depending upon the interferon response, type 1 interferon predominant cutaneous manifestations, yes, we can use anifrolumab. For such patients with probably high TLR7 or with anti-RNP, with RNP levels, we can probably use RNase therapy. But those patients, or predominantly cytopenias or serositis, there's no point in using anifrolumab in them because it's an interferon-independent mechanism which happens over there. And so I think we are moving more into a personalized medicine. We are yet to see the phase 3 trials, and this is probably one compound which we have to keep looking at. With this, I would like to say thank you. Thank you so much.
Thank you, Dr. Ashwin. We'll move on to the next speaker, Dr. Hema, who's Assistant Professor, Senior Assistant Professor, Government Stanley Medical College, Chennai. She has contributed chapters in various books, Rheumatic Rarities, Manual of Lab Investigation in Rheumatic Disease, Rheumatology Primary Care, published 10 plus journals in internationally indexed journal, conducted clinical trial as principal investigator to study the efficacy of biosimilar with adalimumab in rheumatoid arthritis, and has presented various papers in national conferences. Over to Dr. Hema, who will be giving a talk on updates in management of cutaneous lupus.
Good evening, one and all. Thank you, chairpersons. First of all, I would like to thank Rheumatology sir, like scientific chair and organizing secretary, for giving me this opportunity. The topic given to me is update in the management of cutaneous lupus. Before I start my talk, first of all, why should we need to know about the update in cutaneous lupus? Why is it so important? We all know that cutaneous lupus occurs like 50 to 75% in the course of SLE patients. And why we need to treat them aggressively? Because it's one factor which literally causes a psychosocial impact to the patients. It causes too much of depression in the patient. Even when they have a lupus nephritis, they don't mind because they don't know the external implication of the disease. But when they have a cutaneous lupus, really they are so much worried. So we need to update our management regarding cutaneous lupus. But the sad component here is, do we have drugs? Do we have updated drugs in the management of cutaneous lupus? The answer is no, because there is no FDA approved drugs so far for cutaneous lupus except your hydroxychloroquine and systemic steroids. Even though we have this biological therapies like belimumab and anifrolumab, but it is extensively approved for systemic lupus. It is not approved for cutaneous lupus. So I just start this introduction. We all know the classification of cutaneous lupus. So I'll divide my talk into two components. First, we should know what is the therapies available for cutaneous lupus management. And the second part will be like what are the updated. It will be like more of trials because we don't have indicated drug for the treatment of cutaneous lupus. So this is the Gilliam's classification. We all know it is divided into acute, subacute, and chronic cutaneous lupus. And as such, cutaneous lupus, the manifestation is very varied. Some patients may be having only acute, or other patients may be having like both three things like acute, subacute, and chronic cutaneous lupus. Even in that, the manifestation may be varied. Like some patient may be having only a malar rash, or other will be having a lupus paniculitis. So it differs. And what are the predominant cells? This we need to know because now the recent therapies are focused more towards the addressing the cells which are involved in the pathogenesis of the cutaneous lupus. So the predominant cells are the keratinocytes, T lymphocytes, plasmacytoid dendritic cells, because they play a major role in initiating the immune system. We have both the innate and adaptive immune system acting here, and the main interferon implicated in the pathogenesis is type 1. Of course, we have type 3. I would like to thank Ashwin because he has extensively elaborated on the pathogenesis of the SLE. So the existing treatment targets will be like prevention. First, we need prevention, and then we have topical therapies, and of course, we have systemic measures too. So the preventive strategies will be like sun protection factor, smoking cessations, and minimizing the exposure to photosensitizing medications. As I said earlier, there is no new FDA-approved systemic treatment for cutaneous lupus erythematosus for past 60 years. The only approved FDA-approved drug for cutaneous lupus erythematosus are hydroxychloroquine and glucocorticoids. But of course, we have a lot of off-label therapies because why it is off-label therapy? Because the insurance doesn't cover all these drugs. So the off-label therapies are chloroquine, quinaquine, we have your mepaquine, and systemic therapies, methotrexate, MMF, and other therapies like dapsone, retinoid, oral retinoids, thalidomide, lenalidomide, all these we have. rituximab, belimumab, and anifrolumab, but of course they are not approved for cutaneous lupus, they are approved for systemic lupus. So we need to have a targeted therapies. If you choose a targeted therapy, definitely it will be effective to treat the cutaneous lupus. So this is regarding the pathogenesis. I think we heard a lot about this from Ashwin. So basically what happens, what is the most predominant cell at the risk is the keratinocytes. So this is initiated by, so what are the triggering factors? It will be the UV radiation. So it causes damage to the keratinocyte, and what happens is there is a defective apoptosis. There are a lot of nuclear debris that initiates the immune system, and we have the cytokines released and a lot of cytokines. And the principal cells implicated are the plasmacyte or dendritic cells, and then T lymphocyte and B lymphocytes. So what are the topical therapies? Topical glucocorticoids. Here, usually, whenever I see a cutaneous lupus, I refer to a dermatologist because I don't have much experience with these topical therapies. So it's better to have consult with or coordinate with our dermatology colleagues for an effective management of the, the patient. So topical therapies will be glucocorticoids. In that, we have the fluocinomide, which is more effective than hydrocortisone, and it is usually prescribed for circumscribed lesion, like you have the lesions over the scalp, palms, soles, or the hyperkeratotic lesions. Normally, we don't choose topical glucocorticoids much for the facial skin lesions because it causes skin atrophy. So these glucocorticoids are preferably chosen for the other parts, like palms and soles, or when you have a hyperkeratotic lesions. But of course, you can use topical calcineurin inhibitors for the facial skin lesions. The normally used will be your tacrolimus 0.1% cream formulation that can be used for the facial skin. For extensive skin lesions which have we tend to have a scarring or we have refractory lesions, then it is the point where you have to use a systemic treatment. And the first line of systemic management will be always hydroxychloroquine or chloroquine. And the topical retinoids are chosen for hypertrophic LE lesions, particularly when we have a DLE kind of lesions. And these are the therapies used, like you can use tretinoin gel, or you can use tretinoin cream, or you have tocoretinate. So all these things, I think the dermatologists will use it in a better way. So these are the topical therapies available for cutaneous lupus. Of course, we don't use therapeutic UV radiations, but some dermatologists, they do use cryotherapies for the refractory cutaneous lesions, and even they use laser therapy. Sometimes like pulsed laser therapy may be used in refractive skin lesions, particularly when they have a telangiectasis. Systemic therapies, as I said earlier, the first and the foremost will be your anti-malarial treatment. So in this, we have your hydroxychloroquine. It can be used for severe and disseminated skin lesions, and of course, the lesions which have the risk of scarring. You can choose either a hydroxychloroquine, chloroquine, or mepacrine, but don't combine chloroquine and hydroxychloroquine, but hydroxychloroquine can be combined with mepacrine. And coming to systemic steroid, normally we use oral glucocorticoids. The dose will be 0.5 to 1 milligram per kilogram body weight, but normally we don't give this systemic steroid more than 4 to 6 weeks. Normally we restrict to 4 to 6 weeks, and then we try to taper this oral steroid. And it is extensively used for your severe and disseminated skin lesions, but you use along with your antimalarial therapies. The methotrexate will be the second line of therapy, and it is most commonly used for your subacute cutaneous lupus and discoid lupus erythematosus. And oral retinoid, again a second line of therapy, particularly when they have a hypertrophic skin lesions like a DLE lesion, and the dosage will be like 0.2 to 1 milligram per kilogram body weight, and again you can combine with your hydroxychloroquine. Dapsone, yes, it is a first line of therapy for bullous lupus erythematosus, but it becomes a second line of therapy for refractory cutaneous lupus or a subacute cutaneous lupus, or you can use dapsone is very effective. Study says that dapsone is very effective in lupus paniculitis when you use with hydroxychloroquine. Of course, MMF, it becomes a third line of therapy because normally we use MMF when the patient has got an underlying systemic disease. So MMF becomes a third line of therapy for refractory cutaneous lesions, and it's always used in combination with the antimalarials. This is surprising to know that this azathioprine, cyclophosphamide, or cyclosporine doesn't have much effect over the cutaneous lesion. Though it is used in the systemic disease, As such, for cutaneous lupus, these drugs are not much effective. Normally, we tend to use azathioprine, like steroid-sparing agent, but it is not effective for, exclusive for cutaneous lupus. And thalidomide and lenalidomide can be used in refractory cutaneous lupus erythematosus, also in verrucous kind of, like hyperkeratotic verrucous lesions. Always these systemic therapies are used in combination with your antimalarial drugs. So the algorithm goes this way. First and foremost will be the prevention. So you advise them to use a good sunscreen, you avoid them to quit smoking, and then if any photosensitizers, ask them to avoid that. Then you need to categorize whether it is a localized skin lesion or it is severe and extensive skin lesion. If it is going to be a localized skin lesion, this will be the treatment. Like you can use a topical treatment. It could be either a glucocorticoids or calcineurin inhibitors depending on the site where it is involved. And then if there is no response, then you add a hydroxychloroquine, that's antimalarial to it. If there is a good response, just continue. If there is no response, then you move on to the systemic therapies. You can add either a methotrexate or you can add either a dapsone or retinoid dependingly. And the third line of therapies will be MMF. So this is for the localized skin lesions. If it is going to be a severe and extensive skin lesions, you need to give a combination of therapy. So you combine the topical therapies with hydroxychloroquine or chloroquine with systemic glucocorticoids. If there's a good response, just continue it. If there is no response, as I said earlier, you have to add on with the other systemic therapies with either a methotrexate or an MMF. So this is the protocol for cutaneous lupus erythematosus. This is the thing so far is existing. So now coming to the updates in the managements. There are a lot of trials going on in the lupus, but is it extensively for cutaneous lupus? Not so. What they have found out was they have used this class C, this is cutaneous lupus outcome as a second line treatment. It is not like a primary outcome. So in this we have one approved drug is anifrolumab. I think Ashwin has spoken about that. It is a monoclonal antibody that blocks the interferon gamma receptors. It is FDA approved in 2021. Again, it is approved for SLE. It is not approved for cutaneous lupus, though the study showed that they had a very good class C response with this drug. So the two trials which was used in this drug is, one is a MUSE trial, which is a phase 2 trial where they have seen that the baseline class C score, they have recruited patient with the class C score of more than 10, and the secondary endpoint at the end of 52 weeks, they have observed that there is definitely 50% improvement in the class C score when compared to the placebo. And other trials are the TULIP 1 and the TULIP 2 trials. Again, they have found in that trial that more than 50% improvement in the skin. However, skin was not followed as a marker of clinical improvement in all these trials. So these drugs can be used in the systemic disease when they have an associated cutaneous lupus too. But of course, it helps in the refractory and other severe mucocutaneous manifestations in SLE. The other interferon targeting therapies is cefalimumab. Again, we have trials, but it is not approved. The other drug is AMG 811. It is under trial actually. So the next will be Janus kinase inhibitors. We have here is ducavorasitinib, which is an TYK inhibitor. And of course, we know that when the TYK is inhibited, we have a lot of downstream inhibition of many cytokines. So in the noted trial here is the PASLE trial, which is a phase 2 trial in SLE, where the patients were randomized to receive like 3 milligram, 6 milligram, and 12 milligram of this drug. And the secondary endpoint at 48 weeks, they have noticed that definitely they had a good class C response, like more than 50% class C response was noted in this, this particular molecule. But there are currently other 2 phase 3 trials in SLE, they are underway, and there is a phase 2 trial in exclusively, this molecule exclusively for cutaneous lupus erythematosus, but this is an ongoing trial. The other molecules are the baricitinib. Yes, you know, it is approved for alopecia areata, but it is not approved for cutaneous lupus. The 2 trials which is tried in this baricitinib is SLE BRAVE 1 and BRAVE 2. They noticed that even in this trial, this mucocutaneous symptoms had some improvement. And tofacitinib, of course, it is not, actually it was discontinued when they tried for DLE because they could not recruit patients. There is a study which showed that only 3 cases were there in that particular study, so they couldn't continue that study. And but they noticed that this topical ointment, tofacitinib 2% ointment was effective. There's a case report actually. actually in the recalcitrant periorbital DLE lesions. The other drugs are the filgotinib and landraplenib. These are a tyrosine kinase inhibitor again. This is phase 2 randomized double-blinded trial where they found that again, they had a good classy response, but even though it is not a primary endpoint, a secondary endpoint, they found that they had a good classy response. The other drug or delgocitinib, which is a phase 2 trial. It is again a CHIK and JAK 1, 2, 3 inhibitors, but it is not continued, it was aborted. And, but again, they have found that the ointment form is useful for the subacute cutaneous lupus. And other drug is ruxolitinib, which is an ongoing trial actually, where they found that the classy response was good with this particular drug, particularly when it is used as a cream formulation, that is 1.5% cream formulation, that too in a DLE lesion. So these are all ongoing trials, but they have not yet been approved, or it is not exclusively for cutaneous lupus erythematosus. Regarding the B-cell therapies, yes, belimumab, we all know it is approved for lupus, and they have shown effect for diffuse and resistant CLE lesions. And the other components which were effective in this particular molecule is the vasculitis, rash, mucosal ulcer, and alopecia. They showed a good response with this particular molecule. And there is a phase 3 multicentric 24-week trial called belly skin trial, which is now underway to investigate the efficacy, particularly in the refractory skin manifestations. Rituximab, as such, we know that in Lunar and Explorer trial, even for per se for SLE, they don't have much value, so it is not very much effective in a cutaneous lupus erythematosus. And the T-cell therapies are the two molecules. One is daprilosumab, which is against a CD40 ligand, and this is again is awaiting recruitment, but it is not a skin-specific outcome measure, but basically it is for lupus. And other is lulizumab, which targets CD28, which is again a double-blinded phase 2 trial, but it didn't meet its primary endpoint, so it is also not much effective in cutaneous lupus erythematosus. The other one is dendritic cell targeted therapies. This showed a very promising result, like litifilimab, which is against your dendritic cell antigen. The trial is LILAC trial. Basically, there are many parts of this trial, but this part B phase 3 trial is underway, and it is exclusively for the cutaneous skin lupus. And other molecule is daxidilimab, which is against immunoglobulin-like transcript 7, and phase 1 study showed a good classy response, but the phase 2 trial is underway, and it is for moderate to severe, exclusively for DLE skin lesions. This is cereblon targeting ligands. In that we have iberdomide. Here again it is abandoned because they couldn't get good results with this, so there is no further phase 3 trials. So this is what this algorithm of ACR so far. All patients, yes, sunscreen, smoking, quit smoking, and vitamin D supplementation, of course, need to be considered. Mild disease, you go with the topical therapies and topical calcineurin inhibitors. Mild to moderate, you need to give them antimalarial, either a chloroquine or a hydroxychloroquine. Moderate to severe disease, synthetic DMARDs, either in the form of methotrexate, MMF, azathioprine, and cyclophosphamide is not much beneficial. Thalidomide and lenalidomide can be considered. Biological therapies, yes, belimumab and rituximab, those belimumab scores over rituximab, and other therapies are retinoids, IVIG, and laser therapy. So these are the drugs available for the cutaneous lupus erythematosus management so far. So whatever the above said therapies are only in the trial phase, we don't have any updated molecule for the management of cutaneous lupus. So I conclude, the current treatment regimens for CLE comprises antimalarial, steroids, and immunosuppressives. Immunosuppressives are reserved for only severe cases. We know that skin greatly contributes the burden of the disease, so really there is a need to develop a specific, targeted therapy for this cutaneous lupus, and so further studies are needed in this field along with the collaboration of the dermatologists. Thanks for the opportunity. Thank you so much.
We can have the questions with Hema, starting with Hema, then the other speakers can answer.
But that is, I don't have experience with that, sir. But dermatologists are using it. But but tofacitinib molecule is as such is used for alopecia, sir. Many dermatologists are using for alopecia, but it is not for cutaneous. Generally for alopecia areata they are using. Creams, I am not sure, sir. But studies, there are 2 studies which showed that it is used for recalcitrant, cutaneous lupus.
It's available in India. It's available in India. So.
Any other questions to the other speakers?
Sir, make a comment. Sir, John Matthew. Vishnu, actually, very nice presentation. Actually, this anti-myositis specific antibodies, because there is a pattern in which these patients behave. Data shows how the Caucasians behave and the Far East people behave is different. Severity and the extent of organ involvement. So we had 2 clusters of anti-MDA5. So initially we were all very aggressively looking for rapidly progressing interstitial nephritis, interstitial lung disease, but our patients did not have actually. Only we had close to 50 patients in 2 cohorts. Only 2 of them had rapidly progressing interstitial lung disease, unlike what we see in the Far East people.
Even I had a patient, even she had an ulcerative disease with no myositis. She had MI2 antibody positivity and she had a rapidly progressive ILD. I don't know why.
So it's
yeah. In our population, maybe we have to do more research.
Yes, it may be different. Yeah. Similarly, anti-SAE, we have about 19 patients and none of them had a malignancy. So it's, that poster is here actually.
Yes, sir. We have to do more of racial studies from the Indian subcontinent to say that this is more of the Eastern Asian and the Japanese cohort what we know. The literature are only about that.
Any more questions to Ashwin? Thank you very much, all the speakers, for the wonderful presentation and audience for the active participation.
Thank you, sir. Thank you, ma'am. I request the chairpersons to present the mementos to the speakers.
So we request everyone to give a very good applause for the speakers.
I request Dr. Ashwin M. Nair to present the memento to Dr. Mahendranath, sir. I request Dr. Hema to present the memento to Dr. Porkodi, ma'am. We will move on to the next session. This session will be chaired by Dr. K. Shanmuganandan, sir. He is currently the Professor of Medicine in Sri Balaji Medical College, Chennai. And it is also chaired by Dr. Emil J. Tachil, sir. He is a consultant rheumatologist in Lord's Hospital, Cochin. He is consultant rheumatologist in Avitis Hospital, Palakkad, and he's also the consultant rheumatologist in Elite Hospital, Thrissur. I request the chairpersons to come to the dais to chair the session.
Good evening. This is the last session, so without much ado, I would request Dr. Jijit to start his talk on screening and prophylaxis of OI in patients with autoimmune rheumatic disease. He is professor of medicine in Thrissur and in charge rheumatology services in Government Medical College of Thrissur, and he has got 15 publications and he has written a textbook chapter. Please start, sir.
Okay. Thank you, organizers, for giving me an opportunity to talk on this topic. So, the chronic and opportunistic infections are a significant cause of morbidity and mortality in patients with autoimmune rheumatic disease. Now, anti-rheumatic treatment and high disease activity both are associated with high infection rate. Now, during escalation or change in treatment also, there can be a reactivation of latent infections. Now, RA, SLE, myositis, vasculitis, this as a disease itself also increases the risk of infections. So, I will be basically discussing the 2022 guidelines by the EULAR, where they have stressed 4 important points. As is discussed, the individual risk factors, the 4 points that are discussed are the individual risk factors should be assessed. This is because infections are more common in patients with ILD, like treatment history is very important, history of contact with people with TB, and past history of infections, lifestyles, habits, vaccination status. All these are very important when you are to make a decision regarding what all screening and what all prophylaxis should be given to patients with rheumatic diseases. Also, as the medical field is expanding, multi-specialty collaboration is also stressed by the EULAR guidelines, and also national and recommendations should be followed. And the rheumatologists should be proactive in managing and also screening and also giving prophylaxis in their patients with the rheumatic disease. So these are the 4 things that has been stressed by EULAR as the principles in these recommendations. So for the purpose of recommendation, EULAR has also classified that the drugs into 4 categories. This includes the biological and targeted synthetic DMARDs. Here you can see that apremilast is excluded. Conventional synthetic DMARDs, they have, because they have drugs like methotrexate, leflunomide that we routinely use, do not have very high immunomodulatory or immunosuppressive effect. They also has been excluded from the conventional synthetic DMARDs, and it has to be done in a case-to-case basis. The third drug that are suggested are the cyclophosphamide, the mycophenolate and all, and last is glucocorticoids. Regarding glucocorticoids, we have to remember that the risk of infection rises 10 times at a dose above 20 milligrams. So for all practical purposes, the recommended, for the purpose of risk assessment, glucocorticoids dose more than 20 milligrams can be considered as the drug dose. So EULAR recommendation has addressed basically 6 things. One is the latent TB diagnosis, screening and diagnosis, hepatitis B, hepatitis C, HIV, varicella zoster post-exposure prophylaxis, and PCP prophylaxis. So let us go to the latent tuberculosis. So whom should be screened for latent TB? As we all do, all patients starting on a biological DMARDs or targeted synthetic DMARDs. But should we screen for our routine conventional synthetic DMARD patients? So the EULAR has identified high-risk groups who has to be screened for latent TB, and they include people who are on more than 15 milligrams of prednisolone, and we are planning to give it for more than 4 weeks. And also patients with TB risk factors, and these include alcohol, smoking, people living with TB, people living in endemic areas, for example India, and also malnutrition. So if these accompanying TB risk factors are there, or if they are evolving over time, so as you linearly follow up the patient, these patients may have acquired these sort of problems. So in those cases, we should always be proactive and looking for latent TB infections. So what tests are to be used? Chest X-rays, IGRA, and skin tests for TST are not at all advised because they have because their TST may be affected by glucocorticoids, TMARDs, or immunosuppressants. So first we have to rule out active TB infections, and the Indian guidelines says that the target population whom we have to go for latent TB detection are the people who are on immunosuppressive therapy and anti-TNF agents. Okay, so should we retest? So we are giving biological therapy for patients with tuberculosis, with for rheumatic disease, and you have ruled out latent TB, and you are following the patient. Should we retest? This is one question that is always asked by in our mind. So it is quite possible, the answer is yes, because it is quite possible that they become positive over a period of time. But when the exact time is not determined. And this also should be, the decision regarding this should also be considered if by periodic rescreening should be considered if the risk factors exist. So this is the importance of risk factors. Always look for risk factors which can develop over time, and if these risk factors come out in a patient whom you are giving biological DMARDs, you may have, and also depending upon the clinical picture, you may consider retesting for latent tuberculosis. This is the EULAR recommendation. And what is the how to treat latent tuberculosis? We have various regimes, and the most common one that is used is the INH rifampicin for 3 to 4 months. Now we have the NTEB program where tuberculosis prevention therapy is given free of cost to all patients where you are suspecting or where you are planning an anti-TNF therapy. And they have various regimes, but locally, depending upon the availability, the tests are also, now the quantiferon TB golds are also, tests are also given free of cost to patients. And you can actually give refer them to the anti-EP so that they will get any of these based upon the local availability. They can either get a 6H regime or 3HP regimes, which are available through the National Tuberculosis Elimination Program. Okay. The second important thing is the hepatitis B. So whom should be screened for hepatitis B? Ideally, all patients whom we are considering CS DMARDs, biological DMARDs, targeted synthetic DMARDs, immunosuppressants, or glucocorticoids should be screened for hepatitis B. So it is actually just like a universal screening thing. And how to assess HBV reactivation? The important problem with hepatitis B is that it can reactivate on when you give biological drugs or steroids or other drugs, anti-rheumatic treatments. So the first thing that we should do is find out the HBV status. So how to find that? That is by doing the hepatitis B antigen, hepatitis B core antibody, and also by doing the HBV DNA. So, and based upon that, you can classify patients as unexposed patients, vaccinated patients, carrier, where they have chronic hepatitis B surface antigen positivity, and another state is resolved hepatitis B, where the hepatitis B core antigen will be positive, antibody will be positive, but they are HBsAg negative. So, what to do for HBV carriers? That is HBsAg positive, and you are planning for an anti-rheumatic drug treatment, especially the B-cell therapy. They should be referred to a hepatologist for upfront antiviral treatment. What to do regarding the resolved hepatitis B? In those cases, we have to go for a hepatitis B virus DNA. If the virus DNA is positive, you can give hepatitis B treatment after referring to a hepatologist. But if the hepatitis B DNA is negative, the decision should be again in consensus with the hepatologist. You will have to be carefully looking for other risk factors that might come during the treatment. But we should remember that the hepatitis B surface antigen may sometimes be negative even in the presence of a latent hepatitis B infection. So there are certain situations like anti-HBC window, low-level hepatitis B carrier, recovery from hepatitis B. So these are situations where always one should go for hepatitis HBsAg plus anti-HBC, which will help you to make decisions regarding whether the patient is actually having a problem of hepatitis B reactivation, especially in the setting of drugs like when you are planning therapy with rituximab or abatacept. Now, rituximab, abatacept, and hydrosteroids. These are three drugs that has been found to be very highly associated with hepatitis B reactivation. So we have to be very careful, and just by doing hepatitis B surface antigen won't be sufficient in those cases. So what is the dose of steroids where you should be very careful? The American Gastroenterology Association says that if the patient is receiving at least 10 milligrams of prednisolone or equivalent for more than 4 weeks, one has to be very careful and go for hepatitis B surface antigen plus core antibody to decide regarding the need for prophylactic antiviral therapy. So the other disease that is of concern is hepatitis C. So again, just like that, just like hepatitis B, all patients whom we are planning an anti-rheumatic therapy should be ideally screened for hepatitis C. Mind you, the CAR test is not good at all. You have to go for ELISA. And the best gold standard would be HCV RNA, but this will not be cost effective. All patients, but a patient with an elevated ALT, which is persisting, and have clinical symptoms or history where there are risk factors of hepatitis C, it is better to go for a ELISA plus HCV RNA, especially if they are being planned for triple immunosuppression or combination biologicals like that. So, interestingly, TNF inhibitors has been found to be associated with HCV reactivation, and in those setting also, carefully looking for hepatitis C virus is very important. And if HCV RNA is found out, there are effective treatments nowadays. 3 months treatment is available, and it is also available in the National Hepatitis Program. So you can easily treat hepatitis C with oral drugs. Combination is available. So in consultation with hepatologist, this can be done. And again, HIV is another important issue that can complicate your therapy. So again, all classes of drug, it is better to screen for HIV, because even though no robust data is there regarding the safety of treatment with DMARDs or anti-rheumatic drug in patients with HIV, screening for HIV should be undertaken prior to treatment with biological disease modifying agents, because a proper HIV care would be very important in preventing infection in such situation. A very important recommendation regarding varicella zoster has been made by the EULAR, but they have not given a thorough clear recommendation because national policy, because of the national policy variations and availability of immunoglobulin testing and all those things in various countries. But it is always better that all people with rheumatic diseases where you are planning biological or anti-rheumatic therapy be screened for varicella zoster immunity. This can either be done by a clinical documentation that the patient had a past history of chickenpox. If not, better go for a level. The protective level is considered as 150 international units, and all patients should be advised regarding post-exposure prophylaxis during a contact with varicella zoster. So you can tell your patients that if you have a contact with household contact with chickenpox, and if you are taking anti-TNF or biological agents or any rheumatic drugs, hydrosteroids, anything drug, the importance of post-exposure prophylaxis should be stressed. This is very important. And what is even if the immunoglobulin levels, the protective levels are not available, the one good thing that we can advise is starting an antiviral from day 7 to day 14. So you can ask these patients to take an antiviral prophylaxis from day 7 to day 14, and the drug of choice is our acyclovir, 800 milligram 4 times a day. From day 7 to day 14 would be the best thing that you can do. IVIG, if the patient is on continuous IVIG treatment, or if the patient has received IVIG in the past 3 weeks, it is better. They may have a protective levels of varicella, immunoglobulins in their blood, so they don't need this prophylaxis. But again, case to base, in a case, you have to take decisions in case to case basis. Okay. So the ideal thing is establishing the immune status of the individual. It can be by looking at the levels of varicella zoster antibody, and if this is not available, or if such a decision is not possible, and if the patient is exposed by a household contact to a patient with a varicella, it is better to give post-exposure prophylaxis. from day 7 to day 14 of the drug, of the disease or exposure, first exposure. This sort of a thing does not stand, or antiviral prophylaxis does not stand in the setting of a herpes zoster. But there is some weak evidence in the case of recurrent herpes zoster infection, especially in the setting of targeted like tofacitinib, where possibility of recurrent herpes zoster might be there. In such cases, antiviral prophylaxis may be considered, but the evidence and recommendation in such a case is very sparse. So it has to be in discussion with the infectious, the other infection disease specialist, that this sort of decision should be taken. PCP is another big problem that is common in patients with rheumatic disease. And again, the association between PCP and rheumatic treatment is basically based on the glucocorticoids. For other drugs, other anti-rheumatic drugs, this sort of one-to-one correlation is not well established. So generally, when you think in terms of PCP, one should think in terms of the risk factors that are there in a patient. And the most important pharmacological risk factor is the co-administration of immunosuppressants with steroids. So when a patient is on MMF plus glucocorticoids, it's like that. So when you have a combination of a steroid plus immunosuppressants, think about PCP. And this often happens in the case of myositis, ILD treatment, like that. So whenever you have such a situation, think about PCP. Another risk factor is persistent lymphopenia. Think about a patient with lymphopenia. Age, pre-existing lung disease, ILD patients, underlying disease. Okay, there is a high association of PCP activation in patients with ANCA-associated vasculitis and PAN and inflammatory myositis and ILD, like that. So, what drug to use? So this is when you have two or more risk factors, it is always good to consider a PCP prophylaxis and start using this. Now, regarding other, the dose of drug that has to be used is one double strength tablet 3 times a week. But if you use a daily regime, it is better because it can prevent against nocardia and toxoplasma also. So, but general use is a double strength tablet given thrice a week. In SLE, there is a higher chance of adverse drug reaction. So one has to be very careful when using PCP prophylaxis with the trimethoprim. Now, regarding other viruses like cytomegalovirus, fungal infections and all those things, the ULR has not made any recommendation because the data is very sparse. But the assessing in a patient whom we are giving very high immunosuppression or using combination drugs, it is always better to identify, like in transplant, it's always better to look for the IgG status of CMV, because if the IgG CMV is positive, the chance that there can be a reactivation of CMV is high. But PCV viral load would be the best, or an increase in the viral load would be the best way to go about in such cases. And decision regarding treatment of CMV or putting them on ganciclovir prophylaxis should be made on a case-to-case basis. Regarding other rare pathogens like non-tuberculous mycobacteria and all those things, the evidence is sparse, but it should be again discussed, decision should be taken based on the case scenarios, general case scenario or individual case basis. Now, the ULR has given recommendation regarding the dietary and environmental advice to reduce the risk of infection regarding Listeria, Salmonella, like that. And since the research, since the evidence regarding all these things, like screening for the fungus and organisms which is rather very rare in patients, latent infections, is very sparse, the ULR recommends that shared decision is the way forward. So the risks, whenever you are giving an anti-rheumatic therapy, the risks should be explained and discussed with the patient, including how the risks can be minimized, and educate them on healthy lifestyle tip managements. Also, educate the patient to identify promptly the signs and symptoms of infection and how to seek relevant medical attention. We should also periodically discuss with the patient regarding such things during escalation or change in treatments also. So if you are escalating the dose of drug, also there is a chance that newer risk factors are emerging. So the patient should be educated regarding that. There are a lot of, for the transplant setting and all, there are a lot of antibodies that can be screened regarding the fungus, NTM like that. But this is not cost effective in the setting of a rheumatic disease. So the EULAR recommendation basically is basically for latent tuberculosis, hepatitis B, hepatitis C. They have given clear recommendations on these things. But regarding the rare pathogens, you have to be, there are no specific recommendations and has to be done in a case-to-case basis. Post-exposure prophylaxis for varicella zoster should be encouraged and proactively looked into. Thank you.
Thank you. Now I hand over the mic to my co-chairman for introducing the second speaker.
So the next topic will be serum biomarkers in interstitial lung disease. Do they have any diagnostic validity? And the speaker is Dr. Subramaniam sir. He is MD MRCP UK and MRCP CC Rheumatology. He's a consultant rheumatologist from Tirunelveli and Velammal Medical College Hospital, Madurai. So we know that ILD, as previously discussed in the other hall, ILD is a important problem that most of the rheumatic problems face. So is there any importance for the biomarkers? That's what we have to know. Over to the speaker, sir.
Thank you, Chairpersons, and good evening to everyone. So I must thank the organizers of South Zone for a fantastic conference in Coimbatore. So I'm standing before the installation or inauguration. So serum biomarkers in interstitial lung disease. That was a topic given to me. So ILD, we all know the current practice is the patient do get symptoms and then being investigated non-invasive with a chest X-ray, CT scan, and also lung function test. And some people may need like a chest physician review and also biomarkers looking at, and echocardiogram and right heart catheter also need to be done. And biopsy is becoming obsolete because other markers are supportive. But that's where we are right now currently. But there's a lot of diagnosis going on with the biomarkers. As you all know, biomarkers is where it has to be very specific and sensitive and pick up important patients who have definitely evidence of interstitial lung disease. This is more pathogenesis, which has also transformed in the last decade with the lots of pathogenic factors identified and also even up to the NIBS, which is being used for managing interstitial lung disease. It's a dreaded complication. Unless we identify early, it's difficult to treat or try to get reasonable quality of life for the patients. So I just try to look into the available evidence. Lots of studies have gone on. So nearly 3,300, if you Google it and PubMed for ILD and biomarkers. And if you use artificial intelligence, there are still about 1,300 evidence there. So a lot to share with you. But I thought I'll share with you about the last 4 years of developments. It may be a bit boring, but that's where we are. So still, it is a very fluid situation in terms of specific biomarkers for identifying the interstitial lung disease and which subset of patients who do have worse prognosis and like that. So biomarkers play a vital role in early diagnosis, whether you do a non-invasive investigation or invasive like bronchoalveolar lavage or invasive biopsy. And it has to be a more prognostic as well as a diagnostic. And the contribution, the recent interventions and the personalized medicine has come into play, but still a lot of unmet need in regards to the biomarkers for interstitial lung disease. So these are like a summary of the common important biomarkers which has been studied a lot. So the one is looking at the epithelial cell dysfunction. So it's called as KL6 or Krebs-von den Leeuwen. It's a transmembrane mucoprotein. which is more fibrogenic in the alveolar cells and is more sensitive for picking up for the diagnostic point. And then extracellular matrix proteins like in a MMP1 or 7 or 12, they also have been studied a lot with regards to diagnosis. And then immune dysregulation markers like chemokine motif ligand 18 and also IL-6. So they have been found to be involved in lung involvement in ILD, but they are more prognostic rather than diagnosis. And SPD, which is the surfactant protein D, which is also highly sensitive for ILD, but it's less specific. And other agents like pro-fibrotic cytokines also being studied in the last few years. So just about the KL6, which is the most studied one. So they are expressed in alveolar epithelial cells, and it's high risk of development of ILD. So if we pick them early, more predominantly in scleroderma and systemic sclerosis, and less commonly with RA-ILD patients. And similarly, serum amyloid acute phase protein, that also has been found to be in alveolar cells and more fibrotic gene expression. And they also been found in other patients like obesity and also hyper-responsiveness. So it may be picking up other ILDs too. So these two are more studied for IPF type. So this is like a landmark study from UK. So this is UK biomarkers in interstitial lung study. This was published last year. And they have studied about the IL-6 and FER and SMRP. These are the biomarkers they studied. And they looked at all the ILD patients across the spectrum. And what they observed is serum level of IL-6 and FER levels were higher in both groups, where you have ILD patients and non-ILD patients. With the scleroderma and the rheumatoid group. And ILD patients, KL6 appeared above the cutoff for patients with the diagnostic value. So KL6 is more specific for diagnostic, irrespective of the final diagnostic extent of disease. And it's always a biomarker for patients with lung disease, whether it's a idiopathic or autoimmune form. So this is a landmark study from UK. This was published, presented in the EULAR recent conference too. And this is another one from Raghu and et al. Group, published earlier. And they also showed that higher levels of KL6 and high HSPD, which is associated with the increased risk of RA group. This is Korean study. RA and ILD, they looked at it, and reasonably good number, and they followed it for over a 7 years period. At follow-up, the increased level of KL6 and also MMP7 levels were associated with risk of progression with regards to ILD. So limited group, different countries, they look at different biomarkers, but altogether it's a composite index is required that is very, very difficult to get from nowadays. So these are biomarkers in blood-related IPF, which means serum biomarkers predominantly. So apart from SPD, which is SPA, which I said earlier, you also have MMP7, KL6, and there are other biomarkers still being studied in different countries and different types of IPF patients. And there are other markers like in exhaled breath. So they have looked at nitric oxide and also volatile organic compounds in patients with these IPF. So potential applications are there, but still in early stages, infant stages. And there are biomarkers in the sputum. So that also being looked at. So they are like cytokines of chemokines and IL-17 and growth factors. They are being studied. But again, they haven't come up to a reasonable conclusion with regards to specific efficacy or like sensitivity. This is another one from a Chinese group. So inside the future erections, they looked at the genetic factors as well as the imaging and also the blood-based. And they also suggest or show that SPD, which is a surfactant protein D, and also KL6 were worse prognosis in patients with ILD or interstitial lung disease. And MMP7 is also found to be heightened risk of fibrotic activity and axillary disease progression. So this is last year from Germany group. So serum biomarkers reflective of different pathogenic process, scleroderma with ILD. So this is a very good paper too. So they also showed that the KL6 and SPD, and along with CCL18, and the new one is the endothelial injury matrix remodeling protein, and that also showed higher values compared to the non-ILD patients or patients who had scleroderma without ILD. So they looked at the different statistics and also linear mixed model. So I'm not going to go detail about that, but the conclusion was, so diagnostic biomarkers for systemic sclerosis with ILD, you have a combination of KL6 and SPD will be beneficial for identifying patients who are at high risk of rapid progression. So this is utility of serological biomarker panels for ILD. This is published 4 years ago. They also suggested, looking at the logistic regression model, KL6 and SAA, which is serum amyloid protein, have a best performance with the discriminating factor of 0.81 compared to IPF than hypersensitive pneumonitis and other sarcoidosis. So combination of serobiomarkers definitely help to a reasonable extent for us to stratify or risk stratify the patients with severe disease. So this is like an area under the curve. You can see the blue is about the white cells, and the red is the KL6, and the CRP is the green one. So this is for patients with diagnosis of sarcoidosis, and you can see compared to other ILD, this is specific ROC curve, and this is patients with IPF. So again, it's a black one is a systemic amyloid protein, and the KL6 is the red one, and that's ROC analysis. So this is again a recent paper, serum metabolites as biomarkers in scleroderma with ILD. So this is a predominant disease group. So apart from the biomarkers, whether metabolic factors or metabolic proteins can be identified. So have they shown that the L-leucine and xanthosine, they are more negatively correlated with changes in the FVC predicted. So I'll show in a few slides later. So this is scientific reports from 2020. So these are the proteins they have looked at. So L-tryptophan and also L-methyladenosine. And it's A group is about the healthy volunteers, about 12, and also scleroderma versus progressive, rapid progressive ILD. So the serum metabolites profiling, that showed that changes in levels of L-tyrosine, L-tryptophan, and also L-methyladenosine. So they distinguished hypersensitive pneumonitis from scleroderma, and alterations definitely show that it's a progressive ILD. And the best performing discriminators were L-tryptophan and also leucine. So those two were specifically positive about in patients with stable SSC ILD. So that's about the scleroderma ILD and RALD. Then we look at other diagnoses like Sjogren's and ILD. So they all can, apart from the other two diseases. So this is European Journal of Medical Research. That's published a couple of years ago, but it's more Chinese and Japanese group. So they looked at the patients with this Sjogren and ILD, and they looked at a good number of patients and a good match. And their conclusions were disease duration and the serum levels of KL6 and TNF-alpha were more discriminating factors in the presence of ILD in these patients. So we all know like ESR and CRP were definitely inflammatory markers which suggest aggressive disease, and these are all additional factors we can look at them. But the question was whether it's valid for clinical practice. So that's the big question. So it's a cost and how it is accessible and available to patients across the country, that also is an issue. So in this study, main factors which are more like a p-value less than 0.01 is age at diagnosis, high CRP, and also KL6, which is high. So that is important note, and TNF-alpha were also high in these patients with Sjogren's and interstitial lung disease. This is similar, the same study, but looked at the absolute shrinkage and selection operator modeling. And so that also suggests it's more specific in these patients with Sjogren's. I'm not going to go into the details of statistics. But the new like a machine learning and also deep learning, which is part of artificial intelligence, I think we probably will have more information on these angles using the intelligence about which biomarkers can be helpful for us to stratify these risk patients. So, ladies and gentlemen, so little summary about the so far talked about the previously established biomarkers for ILD, which are like SPD6 and also KL6. Sorry, SPD and KL6, they are like sensitive for RA-ILD, but its sensitivity is low, whereas systemic sclerosis like ILD, they are more specific and sensitive. And other biomarkers has been looked at. So those were like serum metabolites and also matrix proteins, metalloproteinases, and also sometimes you can also have circulating mRNAs, which also have been dysregulated or found to be dysregulated in patients with RA-ILD, but we have to watch the space whether we get more evidence on that. So whether we can differentiate between different types of ILD, that is another question. So this study showed that MMP7 could be able to differentiate idiopathic pulmonary fibrosis and CTD ILD. And same way, like a VEGF-A in serum levels and also KL6 have been useful in separating that. And whether we could get a diagnostic efficacy or improve the accuracy, that also needs to be looked at. Further studies or research might help us. And whether we can do a biomarker analysis from breath, so that over time we might get that, but still it's a long way to go in that angle. So, so elevated CCL18, which is a chemokine factor ligand 18, is a risk factor that is more mortality predictor, and a baseline high CRP is also showing that it's worse prognosis and rapid progression of ILD. So that further research will continue to evolve, and definitely we believe that biomarkers will have a more angle or more impetus to us to improve our services if we are able to stratify these patients early. But ILD is always a diagnostic and a therapeutic dilemma, because ours is multi-system disease. Many times we have a discussion with the chest physicians, and they tend to blame the drugs or the disease rather than the managing these patients. So the latest paper, which was published this year, so progression in like a PPF or progressive pulmonary fibrosis, whether we have more biomarkers. So diagnostic biomarkers could be apart from KL6, you have metalloproteinases, and we also have extracellular matrix remodeling, the CCL2, 15, 18, and CXCL10. So that is for diagnosis. And for prognosis, you also have, in addition to the KL6 and SPD, YKL40 and also MMP12 could be looked for, whether we have more evidence for that. So with that note, so if you want to follow me, that's a research gate, and I sincerely thank the scientific team and also organizing team for inviting me to this talk, and also the fantastic venue at Coimbatore. Thank you.
Thank you, sir, for the wonderful talk. I think the topic is open for discussion. Jijit, I would like to ask you one question. You mentioned regarding the risk of rituximab and abatacept in patients with hepatitis B. Is there any choice for you in a patient with spondyloarthritis who has got hepatitis B? Is there anything, any biology that we have to avoid or we have to be cautious about?
Hepatitis B?
Yes, hepatitis B.
Yeah. In any case, of course, interleukin-17 has been found to be, inhibitors has been found to have not have those very high risk. But again, we have to weigh the risk factors. Okay, so you will have to go for the status of hepatitis B and see whether the core antibody is positive or not. And if it is positive, go for HBV DNA. And if this is a situation where you will have to make decision. Okay, so interleukin-17 would be the best choice. But again, you will have to weigh the risk of a hepatitis B reactivation also, because the background immunosuppression, the background immunity, and all those things also has to be considered if you are taking the, if you are considering the therapies. Because interleukin-17 has been basically associated with the candidiasis. Did I answer your question, Amil?
Yes.
I don't think Dr. Changappa is there, so we close this session. Thanks to the speakers for wonderful talks, and we close the session officially.
Thank you, sir. I request the chairperson to present the mementos to the speakers.
So request everyone to give a very good applause for the speakers.
Next, I request Dr. Subramaniam sir to present the memento to Dr. Shanmuganandan sir.
A very good applause for the chairpersons too.
I request Dr. Jijit sir to present the memento to Dr. Emil J. Tachil sir.
And now we are moving forward for the next session, that is sponsored symposium.
This session will be chaired by Dr. Abhilasha, who is an assistant professor in clinical immunology and rheumatology in CMC Velu. I request the chairperson to take over the session.
Good evening all. I am Dr. Abhilasha Manvetkar. I am personally honored to introduce my teacher, Professor Ashish Jacob Matthew from CMC Vellore. He has PhD from University of Copenhagen. He is also worked as a clinical research fellow in psoriatic arthritis program from the renowned University of Toronto. He is a recognized member of various professional associations including GRAPPA, ASAS and OMERACT. He has more than 66 publications on his name. I invite him to enlighten us on the topic of long-term safety and efficacy data on secukinumab use in ankylosing spondylitis.
Thank you, Dr. Manvetkar Abhilasha. It's a pleasure to speak when you're chairing. Right, so I understand this is the last session, but I've been asked to do this, so I'll just get into this fast. So I'm going to just touch upon the long-term safety and efficacy, in fact, efficacy and safety of secukinumab in the management of spondyloarthritis. So axSpA, we all know it's a chronic disease. That's number one. It's progressive. It's irreversible. The structural damage is what really causes all the harm there. And of course, the formation of syndesmophytes. Ankylosis, not so much seen nowadays, and that's the reason why the name was changed from ankylosing spondylitis to axial spondyloarthritis. And of course, the major thing which really doesn't get measured is, of course, your disability, reduced functional function, reduced function and impairment in quality of life for the patient. So it essentially warrants continuous management regardless of whether the disease is burning or burnt out, which is always a topic of debate, and there's very seldom we have this burnt out concept, at least now. So what are the approved biologics, what we have in India? We have a whole lot of TNF inhibitors, 4 out of the 5 we have in India, which have been in use for a long time. And then we have secukinumab, which was introduced in 2017. And among the two IL-17s, secukinumab is the only one which is at least approved in India for axSpA for the time being. Now, if you look at the ASAS 20 and 40 response with TNF inhibitors, We see that for adalimumab it was 89% and infliximab it was 84%. There's ASAS20. ASAS40 was around 70 and 63 respectively, with golimumab hitting around 66 and 57. So it's not a bad response rate as such. Now, we can always debate on what is ASAS20 and ASAS40, but given the measurable instruments, they have shown pretty good response in terms of efficacy. Now, looking at the efficacy of secukinumab, now this was, we have data now, probably one of the data, in fact, in terms of published data is there for secukinumab for up to 5 years from the launch of 2017, of course, in India. But we have data from Measure 1, Measure 2, all the way to 5 years. So, and both Measure 1 and Measure 2, in fact, have looked at patients who are biologic naive as well as biologic IR, which is inadequate response patients for TNF inhibitors. So coming to the long-term efficacy benefits, we know that the Measure 2, if you look at it, was a multi-center randomized controlled trial. It recruited 219 patients with active axSpA receiving 150 milligrams subcutaneous or 75 at weeks 0, 1, 2, 3, 4, and then at every 4 weeks. And at week 16, patients in placebo group were randomly reassigned to receive secukinumab. So these actually, the following slides are not really the published data, but we have data from whatever we have collected from the records of the trials from Measure 2. So we see here that there was a sustained reduction in spinal pain, and which lasted all the way to 5 years data out here. Less than 55% of them did have sustained release in terms of relief in terms of spinal pain. Similar to morning stiffness, it started out here, but then the most important thing is how quickly it starts. We see that the effect was out pretty significant at week 2 itself, and it kind of sustained all the way till the 5 years data out here, which about 52% had a mean percentage change in morning stiffness in with axSpA with secukinumab. Sustained inhibition disease activity, pretty much the same. Again, the dip was quite drastic initially, week 2, and then it kind of sustained, and the BASDAI at 5 years was 3.7. Fatigue score was one of the things which we don't really look at. There again, there was a sustained benefit with 47% of them. But here again, we can see the difference, or the graph just goes steeply up within the first 2 weeks. And that is what really counts in terms of fatigue levels. Up to 4 weeks, we can see a difference out here. So these are ASAS. So long-term efficacy for anti-TNF IR patients, it is pretty much the same, all for spinal pain, for BASDAI, and for reduction in total spinal pains, morning stiffness, fatigue at different levels over here. And we can see that right through the graph, you can right across the board, we can see a sustained decrease in overall disease activity as assessed by BASDAI. Fatigue score also is pretty much the same in terms of starting at week 24 all the way to week 260 in IR patients with TNF inhibitors. Quality of life also mirrored the same thing. A little bit on real-life data, what we have from the EuroSPA data. This is published in 2020, in which they looked at the drug persistent level as well as effectiveness in real-life data, which has about 12 registries in Europe. And we see here again that at 6 months, 12 months, over here we have the disease states, and here we have the response rates, and we see there's a significant difference. But the 3 graphs show the red one is for BDMARD naive, the yellow one shows 1 prior BDMARD, and the blue one shows 2 prior DMARD. There was significant difference across the board for these two, the BDMARD naive as well as the more than 2 BDMARD patients. So additional benefits, let's move on to the structural progression, which is the talk of the day, because in fact, a lot happens in terms of long-term issues with spondyloarthritis, and we need to really look into the structural progression aspect of each of those drugs. We know that TNF inhibitor takes about 3 to 4 years minimum to start getting its effect on structural progression, but here we have data which showed pretty much good efficacy. After 2 years, 95.3% of the patients remained free from syndesmophytes. And after 2 years, patients with syndesmophyte as baseline, 70% of them did not develop additional syndesmophyte. So that was pretty impressive in terms of data in secukinumab. Now this was actually a trial which just came up last year. It was funded by Novartis, and it was kind of framed for showing a superiority of secukinumab over adalimumab for structural progression. And the patients were biologic naive patients with active radiographic axSpA with a BASDAI of more than 4 and a spinal pain of more than 4 again, and total back pain score of about more than 40 millimeters, range of 0 to 100. And this group was an enriched population because all of them were HSCRP, which is more than 5, which showed active inflammation, as well as more than 1 syndesmophyte on spinal radiograph. So it was an enriched population, and they received secukinumab 150 on top over here, 300 the second bar, and then which is compared with adalimumab, 40 milligrams subcutaneous. And so the result was not really so impressive, at least from what it was framed. The question was framed in terms of the samples were calculated in terms of showing a superiority of secukinumab, but it turned out that there was no difference between secukinumab and TNF inhibitors, although numerically they showed that secukinumab was marginally better than adalimumab in long term. So here again, we had a comparable reduction in SIJ edema score in MRI across all groups, both for secukinumab as well as TNF inhibitors. So the key takeaways would be radiographic progression over 2 years was very low, and there was no significant difference between secukinumab and adalimumab biosimilar. And safety was consistent with well-established safety profiles both for secukinumab and adalimumab. Now, the whole point is about how early does this start in terms of structural progression. And here we know that secukinumab is known to act early than TNF inhibitors, which are known to start acting in terms of structural progression or to reduce structural progression up to around 2 to 4 years of disease activity. Now, when you talk of safety profile, the other problem is about the low risk of immunogenicity, what we face with TNF inhibitors. The issue is with TNF inhibitors. So here we had a mild transient antibody response with no apparent clinical manifestations. Also a loss of therapeutic efficacy, and this is because of immunogenicity and unfavorable safety outcomes as well. Now, if you look at safety data in terms of low risk of immunogenicity or risk of immunogenicity throughout 5 years, we see that there has been pretty much a modest range, in fact, less than 1% of cases across 5 years with no effect on efficacy and safety of secukinumab as compared to TNF inhibitors. Tuberculosis, we all know this is probably one of the first go-to drugs when we talk about tuberculosis. We know that the incidence of tuberculosis is pretty low when compared to TNF inhibitors. And this is the data for TB activation with TNF inhibitors. And we see that both for adalimumab and for infliximab, it's pretty high number of patients are at risk. Again, more so in our setting, where most of the patients are exposed to some amount of tuberculosis, latent tuberculosis, so to say. So there's low risk of TB with secukinumab due to its unique mechanism of action, and this was sustained through 5 years. And this is about the other infections, serious infections, candida infections, which we do consider a problem with secukinumab. Crohn's, we have data, recent data, which in fact shows that the data is pretty encouraging, because Crohn's was seen just in about less than 1% of patients throughout. This is data for 5 years, what we have in terms of Crohn's and ulcerative colitis. Unclassified IBD, again, less than 1%, and MACE was just around less than. So overall, it was encouraging in terms of IBD events, when it was only less than 1% of events, which is well within the expected background incidence rates. Another data on drug retention, because this again is very important. Now we've started looking at drug retention rates for biologic registries, and this again is data from the EuroSPA registry, in which they looked at retention rates at 0, 3, 6, 9, and 12 months. So we see that even at 3 months or even at 6 months, 6 months actually, so the blue line, or the red one is biological DMARD naive, the green one is 1 prior BDMARD, and the blue one is exposure to more than or equal to 2 prior DMARD exposure. And we see that at the end of 1 year, with the biologic naive patients, we see close to about 80% of them retained on secukinumab, as opposed to definitely the line drops as we have more and more inadequate response to other biologic DMARDs, which is mostly TNFIs. And we see that even with 2 biologic prior DMARDs, we see close to about 75% of retention for secukinumab. So in conclusion, the management of axis spondyloarthritis, secukinumab, of course, is the first IL-17 inhibitor. It offers long-term efficacy benefits over a period of 5 years, and of course, long-term safety benefits about 5 years, for 5 years, and it helps in inhibition of structural progression over a period of 4 years, which seems to be the main thing in terms of data what we have as of today. So thank you very much for your kind attention.
Thank you, sir. Thank you for the informative topic. Anyone, any questions are there?
Secukinumab at 2 and 5 years, there was no progression in people without syndesmophytes and with syndesmophytes, no? Is there some comparative data on that, or just secukinumab?
No, this is the data what I showed was actually from the MEASURE-2 study, in which it is not actually a published data. Whatever it is, there is. But this is data from the MEASURE-2, in which they looked at MSAS scores, and they looked at 2 years and 5 years.
Not MSAS. The secukinumab alone at 2 and 5 years you had shown.
So yeah, that's exactly. So that's 2 years and 5 years data, not published data, but it's part of the trial itself.
So there's something else comparator might be there, which you couldn't.
It is not a a comparative thing.
What if you don't treat? How much will progress and?
Okay. Yeah. So yeah, that's there. But so the whole point of about TNFI and secukinumab, what people say is we talk about TNF inhibitors. Many of the times we say that the structural progression increases in the first 4 years and then it starts acting. But actually what many of them have dissected it, and what people think is it could be the normal progression in the first 4 years, and then it definitely brings down. So this 4 years probably is an arbitrary figure, and that's probably the reason why in SURPASS study it didn't really matter what you use, both TNFI and IL-17 inhibitor. Although IL-17 was numerically better, but again, it was an enriched population with CRP, MSAS, all these things, but still it didn't really meet its endpoint. Yeah, honestly, there's no difference, although we feel that secukinumab, there is marginal data to show that, because enthesitis, again, if you look at it, is IL-17 driven pathology. So we hope that that way it's pretty much the same for IL-23, more so in data with in PSA than in AxSpA, but definitely even in AxSpA, because if you look at AxSpA, enthesitis is quite tricky, because if you look at the SCQM data published about 2022, data on TNF inhibitors. They showed that heel enthesitis was not quite resistant to treatment, and it took at least more than 1 year for the heel enthesitis to tank with TNF inhibitors. But we do have data which shows that IL-17 works better from real life data, not in trials though.
Versus spondyloarthritis manifestations of psoriasis?
Short answer is no. No evidence? Yeah, but we do have evidence in terms of sustaining that's how people have looked at sustaining the biologics. Does methotrexate help? And I think adalimumab, there was one trial recently which was not so favorable. But not in terms of effectiveness, yeah, there's no trial. And nobody would do it.
Hello. Sir, one question from my side. If the TB infection is lesser as compared to infliximab and adalimumab, so how extensively we should do latent TB workup before starting secukinumab?
Yeah.
And
So again, it depends on where you're practicing, right? If you're in a Western country, I don't think people do it, but it's there in the sheet that you have to do a TB workup. So just for, it's more of a defensive thing that we do a TB workup. But certainly if you ask me on a personal level, yes, definitely in India, I would do a TB workup, although it seems to be pretty okay with even starting secukinumab after 4 weeks to 6 weeks of anti-TB treatment, even if the patient is positive for latent.
And second question, sir, you will prefer in a patient of past TB infection, you will prefer secukinumab or infliximab?
I'm sorry, the patient
If a patient with history of tuberculosis infection, you will prefer secukinumab?
Certainly I prefer secukinumab over TNF inhibitors.
Okay, sir. That's all. Thank you, sir. Thanks a lot, sir. Thank you for this talk.
Thank you, sir. I request Dr. Ashish Jacob Matthew to present the memento to Dr. Abhilasha.
So you can give a very good claps for the chairperson. So next, in few minutes, we are going to have the inauguration of 9 South Zone Era Conference 2024. So we'll start up the inauguration within few minutes. So we request all the delegates to stay back for the inauguration ceremony.